We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. Today we are back with our series, The Benchmark, Episode 3. Myself, Sahiti, welcoming you all for today's webinar on Early Pregnancy Symposium. So let me introduce the convener of today's webinar, Dr. Parag Biniwale, sir. Sir is the Senior Consultant Obsgyn in Pune, PG teacher and unit head at Kamala Nehru Hospital, Chairperson-elect of ICUG, President of Pune Obsgyn Society from 2022 to 23, Vice Chairperson ICUG from 21 to 23. I welcome you, sir.
Thank you, Saiti.
It's my privilege to introduce MOC of today's webinar, Dr. Supriya Jaiswal, ma'am. Ma'am is the Chairperson of Adults and Health Committee, FOXY, from 23 to 25, Vice President of Partner Obsgyn Society, Co-Trainer of HPV Project East Zone, Joint Secretary PMS and AGOI Bihar, SOFC Bihar and Jharkhand. I welcome you, ma'am. It's my pleasure to invite Dr. Madan Kambal, sir. Sir is the Consultant Obsgyn and Aesthetic Gynecologist, Chairperson of AMOC Sexual Medicine Committee, Past Secretary and President of Akla Jobi Jivan Society. I welcome you, sir, and I hand over the session to convener.
Thank you. Thank you. It's my pleasure to have in this wonderful series of the benchmark, which is the brainchild of Dr. Sneha Madam. This is the third episode of the benchmark, and today we are having a wonderful webinar on early pregnancy symposium. And I'm lucky to have the esteemed chief guest, Dr. Jaideep Tanks sir, today, and guest of honors, respected Dr. Arup sir and Dr. Sridevi ma'am. And the convener for this series is Dr. Parag Biniwale sir. I welcome Dr. Parag sir and my madam coordinators, Dr. Supriya Jaiswal madam, and all the speakers for today's session and all the respected chairpersons for today's session. I welcome all again. It's my privilege to introduce Dr. Sneha ma'am. Can I have the CV? Dear Sneha madam is the main program director of this series, and she was the Fox Breast Committee chairperson of FOXY last in 19 to 21, governing council member of ICOG. She was the national adolescent trainer for the WHO FPA certified, and she has so many awards in her name, and she is currently the president of IMA Yavatmal and founder clinical secretary of Yavatmal Society and life member of FOXY IMA ISA.
Thank
she
you.
is the dynamic person of FOXY, and I welcome ma'am for your welcome address. Over to you, ma'am.
Thank you so much, Madan. In fact, rather than the so many national and international award, I would love to introduce myself as a hardcore obstetrician with the experience of more than 32 years now. A very good evening to one and all, especially to respected President FOXY, Dr. Jaideep Tank, as chief guest, Dr. Arup Kumar Maji, the National President of ISOPA, and Madam N.S. Sridevi, Emeritus Professor, Pushpagiri Medical College and Hospital, Tiruvalla, as guest of honor. Convener, our dear friend, Dr. Parag Biniwale, the Chairperson-elect of ICOG. Esteemed speakers for today's session, revered teacher, Dr. P.K. Shekharan, I would say the teacher of teachers from Calicut, past Vice President of FOXY, who will be speaking on management of gestational trophoblastic disease. The founder and CEO of MRCOG course, Dr. Bhavna Khera, will be speaking on hyperemesis gravidarum. Dr. Priya Gupta, the president of Kota Society, will be speaking on early pregnancy bleeding. And myself, Dr. Sneha Buyar, will be speaking on the screening strategies during early pregnancy for common disorders during disorders. Our esteemed chairpersons for today, Professor Usha Kumari from Patna, Dr. Sandhya Panikare from Berhampur, Professor Bharati Maheshwari from Meerut, Dr. Jairani Kamraj from Chennai, the President of Chennai, and Dr. B. Kalpana, President of Madurai, Foxy Chairperson for Infertility Committee, Professor Ojaswini Patel from Burla Sambalpur, and of course, Dr. Anita Sabrawal, Professor Usha Kumari, Dr. Dr. Pranjal Sharma, a renowned practitioner from Amravati, and dear friends, our coordinators, Dr. Supriya Jaiswal, the Foxy Chairperson for Adolescent Health Committee, and Dr. Madan Kamre, who is the AMOX Chairperson for Sexual Medicine Committee. A very good evening and warm welcome to all of you for this third episode of Benchmark, which is especially the Early Pregnancy Symposium. I'm sure all the esteemed speakers will extensively cover this topic, and the chairpersons, very experienced and expert in this field, will definitely combine and make expert comments on this. And I'll be very happy to witness the success of this program. I'm here to request all of you humbly once again to bless me and bless the program. I request your blessings for my candidature as Foxy Vice President from West Zone for the upcoming elections. Once again, I thank all of you, and I would hand over once again to the MOC, Dr. Madan Kamre.
Thank you, ma'am.
Whether Dr. Jaideep Tang sir has joined? Has he joined?
Yes, yes,
ma'am. Yes, ma'am.
sir is there.
Okay. Good evening.
Hi, sir. Hi.
Good evening,
sir.
Hi. Hi.
Welcome once again. I welcome you here on this program, and I have just delivered the preamble for this program and
Yes,
discussed.
yeah, I was there. I heard it. Thank you.
Thank you so much, Jaideep. And Saiti, can we have Sir CV? Though the CV is very busy, and all of you know as formally how illustrates the personality with the highly decorated CV. All of you know Sir is the President of Foxy at present, Deputy Secretary, Asia Oceanic Federation of Fox-Gynae. He's the immediate past chair, International Federation of Fox-Gynae. That's FIGO, Committee of Safe Abortion, and he's the past chair, Publication and Newsletter Committee of AOFOG, and so many awards and accolades to his credit. But I would just say, sir, you are the inspiration for all of us. And coming from such a small society, we look up to you as a leader coming forward in Foxy also. Thank you so much for blessing the occasion, and may we have precious words from your side. Over to you, Jaideep.
Thank you. Am I audible, Sneha?
Yes.
Yes, sir.
Yes.
Thank you very much, Sneha, for inviting me for this very important webinar. And congratulations for putting together as the program director this benchmark series. I think this webinar on early pregnancy is very important. I think the early pregnancy is perhaps one part of pregnancy which, in all the hullabaloo about emergency obstetric care, we sometimes don't pay as much attention as we should to it. It is, my privilege to be associated with anything which Sneha does. When she was the chair of the breast committee of Foxy, she had done really remarkable work and set the bar very high for all subsequent chairpersons to come. So congratulations, Sneha, on all the wonderful work that you've done. And I'll wish you all the very best for all your endeavors in the future. I'm also privileged to have Dr. Maji and Dr. Sridevi Madam as the guest of honors. And Sneha, you put together a wonderful program with great speakers like Dr. Bhavna, Dr. Priya, and of course Shekharan sir, who is one of my favorite persons in Foxy, and yourself, of course, as a speaker. And such wonderfully eminent chairpersons, Dr. Usha Kumari, Dr. Sandhya Rani, Dr. Kalpana, Dr. Ojaswini, Bharti, Dr. Jairani, and of course our beloved Anita ji, who's always such a pleasure to meet, and Pranjal. And I'm delighted to see that the convener of your program is my very dear and old friend Parag. And the coordinators are a very dynamic chairperson from Patna, Dr. Supriya, and Dr. Madan Kamble. So thank you very much, Sneha, for putting this together. All the very best for everything. And I wish the webinar and all the future episodes of this program the best of success. Thank you.
Thank you so much. Thank you so much, Jaideep. It's always good fortune to have you. And of course, your guiding words are very precious for us. Thank you so much once again.
Thank you. Thank you.
Thank you. May I request Dr. Parag Beniwale to introduce the guest of honor, Dr. Arun Kumar Maji and Madam.
Yeah. Thank you, Sneha, and good evening. It's indeed a pleasure to have Jaideep as the chief guest, and of course, we have two very eminent teachers as guest of honors. And first is none other than Professor Arup Kumar Maji. Arupda is currently the president of ISOPAB. He's also the president. He's presently professor at the Shantiniketan Medical College, Bolpur in West Bengal. He's the editor of Indian Journal of Perinatology and Reproductive Biology from 2010 to 2017. And he has a huge teaching experience of over 30 years. May I request Dr. Arup Kumar Maji to address us, please?
Thank you, Dr. Borak, for your nice introduction. Respected chief guest dear, Dr. Jaideep, the President Foxy, respected guest of honor, Dr. Sridevi, Madam, Emeritus Professor, and thank you, the Program Director, Dr. Sneha Bhuiar, who is the MOGS Chairperson, Emergency Obstetric Committee, and Founder President of the Vidarbha ISOPAB. I also really feel fortunate and honored to be invited by you for this prestigious webinar, the benchmark, the episode 3. The today's symposium is very important area on the obstetrics, the early pregnancy, and the events and the complications and the screening. This is very important with the fact that it is almost inevitable, and everyone has to manage all the things. The first topic is the hyperemesis gravidarum. So nausea and vomiting is common thing, but sometimes there is a very severe form of hyperemesis gravidarum that is a serious complications, and the patient maybe should be admitted for the ketosis, starvation, and the fluid development. And the topics will be addressed by the Dr. Bhavna Khera, the founder, CEO, MRCOG course. And that will be chaired none other than the Dr. Usha Kumari, professor and HOD, now in Nalanda Medical College, and also the Sundharani Panikrai from the Berampur, the member of the MTP committee. And the topic 2, another very important topic, the early pregnancy bleeding is so common. Another problem in the early pregnancy, and that will be dealt with Dr. Priya Gupta. I think Dr. Priya Gupta is the West Zone coordinator of the Family Welfare Committee with the Dr. Ashish. And the session will be chaired by Dr. Kalpana and Infertility Committee Foxy, and Dr. Ojasini Petal, and the Vice President elect of the National IPOSA, the very enthusiastic lady. And the third topic is the diagnosis of the and management of the HMOL, and that will be dealt by Dr. P.K. Sekaran, the past Vice President Foxy. That will be chaired by the Dr. Bharati Maheshwari, the very dynamic lady of the in the Medical College, Muzaffarpur Nagar Medical College, and Dr. K.S. Jayarani Kamraj. And the last topic, that's a very interesting topic, the very new topic, and coming the new things on that, the screening during the early pregnancy for common disorder, the update that will be dealt by Dr. none other than the Dr. Sneha Bhuiar herself, and that will be chaired by the Dr. Anita and Dr. Pranjal Sharma. And I am very happy to see the convener is the president, that is the chairperson elect ICOG, Dr. Porak, who has introduced myself. And also the coordinators are the Dr. Supriya Jaiswal is always very enthusiastic in all majority of the program. They have arranged so many good program in the Patna in PPHCon last week. And another coordinator is Dr. Madan Kamli. So I hope there will be very good discussion of these important topics on the early pregnancy symposium. Wish you the best success of this webinar. Thank you all again. Thank you, Dr. Sneha. Hope your success in the coming event. Dr. Sneha, thank you all.
Sir. Thank you, sir. Thank you so much.
Yeah, thank you, Dr. Arup Kumar Maji. And may we have CV of Dr. N.S. Sridevi, please. It's a pleasure to introduce Dr. N.S. Sridevi. I don't know whether she remembers, but I had interacted with her way back in 2006 during the AICOG, which was held at Kochi. Welcome, Dr. Sridevi. She's the Emeritus Professor in the Department of OBGYN at Pushpagiri Medical College, and she has a vast teaching experience and she has retired from the government service as Professor of OBGYN from the Government Medical College, Kozhikode. May I request Dr. Sridevi to address us, please? Please unmute yourself. You're muted, madam.
Yes. Can you hear me, sir?
Yes.
Yes.
Yes. Good evening, all of you, especially our President, Dr. Jaydeep Tank, Dr. Arup Kumar, Dr. Priya, Dr. Parag Binwale, all the senior faculty members, and especially my dear Professor Dr. Shekaran, sir. And I'm very glad to be here along with you all for this webinar series. And especially this is important. Why? Because most of the time, all the recent advances have been taken during many of the webinars. And this is a very important topic, that is early pregnancy problems like hyperemesis, bleeding, etc. And I should congratulate the team for selecting this topic, especially all the food topics which are important. And all the best for the webinar. I'm very sure that all the points will be covered during this 2 hours. Thank you, sir. Thank you, madams.
Yeah. No, thank you, Madam Sridevi. And Madan, over to you, and let's start with the program right away.
Yeah. Thank you, sir. I request Sahit to please display the CV of Supriya ma'am. I welcome Dr. Supriya ma'am. She is coordinator for today's session. She is the chairperson of Adolescent Health Committee, FOXY. And I request Supriya ma'am to introduce Parag sir.
Thank you so much. Introduce
We'll straight away go to the session.
Yes. So I just thank all the respected dignitaries, including Dr. Jaydeep Tank, chief guest, and the guest of honor, Madam Sridevi, and Dr. Professor Arup Kumar Maji. And I welcome all of you once again, and thank you for gracing the occasion. We straightway go ahead with the academic session. Now over to you, Mrs.
So thank you very much, Madam. First of all, warm greetings from Adolescent Health Committee, FOXY, Dr. Supriya. And I am very happy and thankful to Dr. Sneha Bhuyar, Madam, who's involved me in this benchmark series. That is one of its real standard program that's going on in the webinar. All the academics that has been in 3 series has been wonderful. So thank you so much, Madam, and regards to all the seniors and dear friends. So to start with the first session, we have hyperemesis gravidarum, topic 1. And to chair the session, we have Dr. Usha Kumari, Madam. She is from Patna. Madam has 30 years of overall experience as medical practitioner and teacher. She is a master trainer for EMOC, BMOC, IPAS, NSBA, UG, PG, and DNB teacher and examiner. She is a very disciplined person, very punctual, published many papers in national and international journals, and chaired sessions in many conferences. Madam is a great academician, and she was very happy to be in this program. Welcome you, Madam. The second chairperson is Dr. Sandhya Rani Panigari. Madam is OBGY consultant, Odisha. She is a life member, Box and IMA, also IMA AMS, secretary FCGP, Odisha, then secretary IMA AMS, Women's Wing, Odisha, and secretary of, she has got many accolades to her credit, and she is also the member of a Oncology Committee, Foxy 2017-19, member Breast Committee, and many other public awareness committee and so on. So welcome you, madam. And may I request Dr. Usha Kumari, madam, to kindly introduce the speaker, Dr. Bhavna Khera. Over to you, madam. Kindly unmute, madam. Dr. Usha, madam, kindly unmute yourself. Madam, you please unmute yourself. Usha, madam.
Usha, ma'am, please
Dr.
unmute,
Sandhya,
ma'am.
I think she's not.
You could call her. I have given the request, ma'am. Please unmute, ma'am.
Yeah, Saiti, please help her. Click on the prompt, no? Otherwise, Dr. Sandhya, if she is around, we can she can introduce the speaker.
Usha, ma'am, please unmute, ma'am.
You are unable to understand.
Supriya, if you can call her properly, technically, if you can call her directly.
Usha, ma'am, you were unmute that time. You can do it.
We did speak to her to begin with.
Yeah.
Supriya, you can introduce Bhavna, and then as Bhavna starts a presentation, call Dr. Usha and help her.
Okay, madam. Okay, sir. So, Dr. Bhavna Khera, is the other chairperson there?
No, we can't see her.
Okay.
You can introduce.
Madam is founder MRCOG course of courses, then venture to help MRCOG candidates, consultant obstetrician and gynecologists. She has got special interest in aesthetic and regenerative gynecology and high risk pregnancy. She is also the head of cosmetic gynecology wing, Institute of Laser and Aesthetic Medicine, New Delhi. She has been the member of Safe Motherhood Committee Foxy, received appreciation award for work in Safe Motherhood Committee Foxy AICOG 2024, Master Trainer for Foxy, FIGO, MGH, PPH Project, Manyata Trainer, contributed chapters in textbooks on cosmetic gynecology. She's also been the winner of Best Paper Prize AICOG 2023. She's the Healthcare Excellence. She also won the Healthcare Excellence Award in 2016, Best Paper Prize IMA North Zone in 2018, Best Paper Prize in AICOG 2020, and presented many papers. So madam has so many accolades to her credit. So over to you for your presentation, madam.
Sorry, I lost my connection.
Okay. So
sorry for that.
It's okay. Dr. Bhavna can start and you can give the comments later.
Okay.
Good evening, everyone. Namaskar from Lucknow. And thank you so much, Dr. Supriya, for such an elaborate reading of the complete slide. And respected Jaideep sir, respected guest of honors, respected Sneha ma'am and Parag sir, and respected chairpersons and my dear colleagues. Today I'm here to talk about the hyperemesis gravidarum and nausea and vomiting pregnancy. First of all, I'd like to thank Sneha ma'am and the Parag sir for making me part of this star-studded gathering today. Thank you, ma'am. Thank you, sir. So let me share my slide. Okay. So today this is about nausea and vomiting, pregnancy and the hyperemesis gravidarum. So basically, first, if we talk about, we all know this is a very, very common topic and we all encounter this in our OPDs day in and day out. Still, with so much exposure, still sometimes it becomes a very difficult one to manage. And recently with the updates which have come with the new RCOG guideline, further things have changed a bit. So I'd like to touch upon those points which have been added or which are the changes in the recent scenario. And of course, keeping the background knowledge intact so that we revise what we have been practicing till now. So basically, nausea, vomiting in pregnancy, most important is the symptoms should appear prior to 16 weeks of gestation. If it appears after 16 weeks, then we don't consider as due to pregnancy. 90% of the pregnant women may have this symptom, and typically it starts between the 4th and 7th weeks of gestation, goes up to 9th week in peak, and then resolves by the 20th week. 90% it happens so, but 10% it can last even up to the end. What is hyperemesis? It is the severe form, which affects almost 0.3 to 3.6% of pregnant women, which really interferes with their quality of life and their ability to eat and drink normally. So the hyperemesis definition, which we have been following till now, is basically a triad. So hyperemesis is a triad of symptoms in which there is nausea and vomiting has led to weight loss of more than 5% pre-pregnancy weight, dehydration, and the electrolyte imbalance. So what is new in this? The recent definition which is given by the RCOG updated guideline is that it can be diagnosed when symptoms start in early pregnancy, nausea or vomiting are severe enough to cause the inability to eat and drink normally, and that strongly limits the daily activities of living. Signs of dehydration are now taken as contributory to diagnosis. They are not the diagnostic points. Ketonuria is not taken as an indicator of dehydration in pregnancy and should not be used to assess severity. So here they have paid more stress on the signs and symptoms and the disability which it is causing to the patient. So what they have done is they have shifted the historic reliance on the objective measures. Till now, we used to take the objective measures as the level of severity, such as weight loss or the electrolyte imbalance. But now it is shifted onto the subjective patient-focused criteria. So which leads to improved recognition, diagnosis, and timely management of hyperemesis, preventing the deterioration of these patients. Now, if I talk about the etiopathogenesis, we all know this long list of factors. Hormonal factors like HCG, estrogen, progesterone levels, then talking about the role of prostaglandins and their effect on the gut, leptin, immune dysregulation, the shifting of the T helper cells, and the formation of the interleukins, effect on the gastrointestinal motility, H. pylori, and psychosocial factors. All these have been enlisted for a long time. So what is new kid on the block for the etiopathogenesis? Hypersensitivity to the vomiting is determined by the hormone growth differentiation factor 15. So now two things are there, HCG and the growth differentiation factor 15. Growth differentiation factor 15 causes the loss of appetite, taste aversion, nausea, vomiting, and weight loss. Variation in the gene for this factor, both in the families and the unrelated individuals, is seen to be associated with hyperemesis. In fact, they have mentioned that this is more correlated to the severity of the hyperemesis. The levels of the GDF15 is more correlated to the severity of hyperemesis rather than HCG level, as we have been reading throughout our lives. What are the risk factors? So young multipara, under and overweight women, multiple pregnancy, molar pregnancy, socioeconomic factors like marital status, lower education, genetics, history of hyperemesis in previous pregnancy and family, and the female fetus. Various biochemical abnormalities which can come up: hyponatremia, hypokalemia, low serum urea, raised hematocrit, biochemical thyrotoxicosis and free raised thyroxine levels because of a common subunit between the TSH and the HCG, Liver function tests are abnormal in up to 40% of the women, and there could be rise in transaminases as well. Now, when we come to history is predominantly about three things. One is you need to have, if there is any previous history of hyperemesis or if there is a family history of hyperemesis. Second is you want to quantify how much is the hyperemesis. So you need to take help of how much is the nausea, vomiting, talking about the tylism, splitting, weight loss, how much is the quality of life being affected? And secondly, we also want to look at what are the comorbidities, because if the patient is taking medications for epilepsy, diabetes, and she is vomiting, then we have to take care of that part as well. Then comes the most important part, that nausea and vomiting is the diagnosis of exclusion. So we need to exclude all the other possible causes, and so our history should exclude other causes. So like history of abdominal pain, urinary symptoms, infection, drug history, chronic Helicobacter pylori infection. So we have to rule out all other causes to label the patient as nausea and vomiting of pregnancy. If I talk about the examination, of course, we'll start with a general examination, temperature, heart rate, blood pressure, saturations, respiratory rate, which could be affected because of dehydration, abdominal examination, weight, and signs of dehydration, such as sunken eyes, dry lips and mouth, oliguria, anuria, tachycardia, hypotension. Signs of malnutrition are again very important. Rapid weight loss, muscle wasting as measured by the mid-arm circumference, and neurological signs such as confusion, nystagmus, ataxia, and could also indicate the Wernicke's encephalopathy. Investigations required. Some are mild for the milder forms, and the remaining we have to do for the serious forms. So the severe candidates. So basically for the milder ones, the urea, full blood count, these are the basic in urine, and the full blood count, urea and electrolytes are required for all the patients. Then in the severe forms, we may like to go for the detailed electrolytes, blood glucose level to exclude the diabetic ketoacidosis. Ultrasound scan, of course, is very important because multiple pregnancy and the molar pregnancy could be presenting with a feature like that. Thyroid function test and liver function test may be required in the refractory cases. Amylase can exclude the pancreatitis. So a detailed investigation may be required in a severe hyperemesis patient. What is the differential diagnosis? Because as I said, we have to exclude other conditions. So what could be the other possible conditions? Some are pregnancy-related conditions like acute fatty liver, HELLP syndrome, preeclampsia, genitourinary like UTI, uremia, gastrointestinal, like I talked about the pancreatitis, or just a simple GERD, bowel obstruction, endocrine disorders, CNS problems, and other eating disorders, which could be just a psychological cause. What could be the maternal effects? How it affects? So significant detrimental effect on physical quality of life and work. And there is also associated increased risk of preeclampsia. Increased feelings of depression, negative impact on employment, household duties, parenting, and the family relationships. Significant morbidity because of dehydration, electrolyte and acid-base imbalance, nutritional deficiency, ketonuria, and loss of more than 5% of body weight. More severe forms can go up to acute kidney injury, liver dysfunction, pneumomediastinum, ruptured esophagus, and the Wernicke's encephalopathy. So it can range from mild to a huge impact on the maternal morbidity and mortality. What are the fetal effects? Of course, there is no chances of any congenital problems, but the increased incidence of low birth weight, small for gestational age, and the incidence of the premature infants is definitely there. Now, as we talk about the management, first we need to score how much how can we categorize into the mild, moderate, and severe. So PQ, PUQE scoring system is the one which is used most often. So there are 3 questions basically which can be asked. In the last 24 hours, for how long have you felt nauseated or sick to your stomach? In the last 24 hours, have you vomited or thrown up? Or in the last 24 hours, how many times you are retching or dry heaves without bringing anything up? And this can be marked from 1, 2, 3, 4, 5, 6. And then it is PUQE 24 score is the total score, which can be highest. So 24 score is the points. It is a 24 score system. The mild, the score is 6, then it is mild. Moderate if the score is 7 to 12. And severe if the score is 13 to 15. This is important because when we talk about mild, moderate, severe, we will also have 3 types of management options. We might have community care, then we have ambulatory care, and then we have a inpatient care. So community care is something which we can do for the patient at home. So oral medications and intramuscular, which can be provided at home. That could be the patients who have mild NVP. Ambulatory care, when I talk of, these patients are not able to take up the oral. So they require some fluids or some IV injections, but you can manage them in the daycare units. And third is when I talk about the inpatient management. So if any one of these is present, then we need to do the inpatient management. Continued nausea and vomiting and inability to keep down oral antiemetics. Continued nausea and vomiting associated with the clinical dehydration, weight loss despite oral antiemetics. If there are other suspected comorbidities like UTI and patient is not able to tolerate the oral antibiotics. Similarly, if there are other things like epilepsy, diabetes, for which the medications are not being tolerated by the patient, so these things can actually lead to admission. What should be the management approach? So of course, we have to start with the dietary modification and the lifestyle modifications. And then we can move on to the pharmacological measures in which doxylamine and the pyridoxine combination is considered to be the first line therapy. So what are the dietary modifications? Eat small, frequent meals to avoid gastric distension. Avoid food with strong odors, taste, spicy foods, and caffeine. Increase protein and decrease high fat and fried foods. Eat dry carbohydrates upon awakening. Avoid late dinner. Just telling a patient to eat a dry toast before getting out of the bed or even before brushing the teeth. Try ginger, raspberry, and peppermint tea. Drink plenty of liquids, but only very small quantities at a time between meals, rather than with the meals. So this is the treatment ladder for the hyperemesis gravidarum. Of course, the first one recommended is definitely the doxylamine and the pyridoxine. After that, if the patient is not getting relief, we can move on to the various levels of drugs. So first are cyclizine, promethazine. These are the drugs which are used as a first-line therapy. They can be used as an oral, they can be used as the IM or the IV dosages as per the requirement of the patient, according to her ability to tolerate the medications orally. Second line drugs which we can add upon is the domperidone or the metoclopramide. Metoclopramide, because of its extrapyramidal symptoms, is still recommended as a short course. The maximum time for which metoclopramide is recommended to be given is 5 days because of its extrapyramidal side effects. Ondansetron still remains the second line drug because of a mild risk of orofacial defects, which is sometimes mentioned. So that still remains the second line drug. If nothing works in the resistant cases, the highest part on the ladder is the steroid therapy, which you can use in the form of prednisolone or the hydrocortisone. So this is a step ladder approach. First, we start with the doxylamine, and then we move on to the group of antihistaminics, then move on to the domperidone and metoclopramide or the ondansetron, and then refractory one to be managed by the steroids. If one of the drug is not working, then we can even combine the drugs from the 2 different groups. So sometimes the combination of the drugs do well better as compared to the single drugs. What about the optimal rehydration regimes? So normal saline Hartmann solution, this is the fluid of choice, and if needed can be potassium chloride can be added to the each pack. We have to daily monitor the electrolytes for these patients and try to recognize the hyponatremia, hypokalemia and manage them as early as possible. Dextrose containing solutions are not recommended. First, they will not treat the hyponatremia, and second, they can exaggerate the thiamine deficient state leading to Wernicke's encephalopathy. So dextrose containing solutions are a big no-no in these conditions. These are the various recommendations by different forums. So ACOG that recommends the pyridoxine and doxylamine is recommended as the first line agent when conservative treatment with dietary and lifestyle changes is unsuccessful. Women with the history of NVP or the hyperemesis in the prior pregnancy are advised to take multivitamin at the time of the next conception. RCOG says the combination of doxylamine and pyridoxine is significantly more effective than pyridoxine alone. And there are safety and efficacy data for the first line antiemetics such as antihistamine, H1 receptor antagonists, and phenothiazines, and they should be prescribed when required. Combination of different drugs should be used in women who do not respond to the single antiemetic. Metoclopramide is safe and effective, but because of the risk of extrapyramidal effects, it should be used as a second-line therapy. DCGI, that also recommends the formulation of doxylamine 10 mg and pyridoxine 10 mg, and it is approved for the treatment of nausea and vomiting. Initially, we can start, if we are taking the 10 mg doxylamine tablet, then 2 tablets can be started at bedtime. After then, you can increase it to 3, and if doesn't work, the maximum 4 tablets be given to the patient. If you are managing the patient for the inpatient, then don't forget to do the VTE scoring for the patient. Hyperemesis gravidarum is the transient risk factor for the venous thromboembolism, and patient will need low molecular weight prophylaxis for the period of the hospitalization. That is a very important thing if we are going for the inpatient treatment. So because of the dehydration and the immobilization of the patient, the risk of VTE increases many folds, and it is given a score of 3 for the transient factors. Antenatal care is generally only affected if it is hyperemesis. We may need serial scans to monitor the fetal growth, as there is increased risk of preterm birth and low birth weight. And we can offer the psychological and the social support to the patient. Indications for pregnancy. Of course, we never want this, but 10% of women may require to terminate the wanted pregnancy due to this condition. And basically, they do not respond to any of these management options. Unfortunately, it is still required sometimes. What are the long-term effects of the condition in mother? Increased risk of the PNG, the anxiety, post-traumatic stress disorder, postpartum risk. The risk of recurrence in the future pregnancies is high, that is up to 50% to 81%. There is small increase in the anxiety disorder, this testicular cancer, attention deficit hyperactivity disorder, and autism is also seen in the children of the mother with hyperemesis gravidarum in the long term. Symptoms of NVP should resolve rapidly after the birth. Where symptoms do not resolve, further investigation should occur with the referrals to endocrinology and the gastroenterology. Case reports have highlighted that hyperparathyroidism can be a potential differential diagnosis in the cases where hyperemesis does not resolve postnatally. So the word of caution, if it still doesn't get resolved by the term, we have to look for other important diagnoses as well, which are of course uncommon, but yes, that is required. What we can advise to the patient for the future pregnancies? There is high risk of recurrence. So earlier she can start the lifestyle and the dietary modifications, and with the slightest appearance of emesis, she can start with antiemetics quite early. So just to conclude, the key things are hyperemesis gravidarum is a complex and multifactorial condition with significant adverse effects on quality of life. As soon as possible, we should make the accurate diagnosis. And with the new recent definition, we can make the diagnosis with the clinical signs and symptoms only. Hyperemesis gravidarum is a diagnosis of exclusion. So we should not forget to rule out all other important conditions which can cause nausea and vomiting. Modified 24-hour score is the one which is required for the further management planning. Hydration and electrolyte management to be done with intensive monitoring care, and proper treatment with individualization is required. Thank you so much for your patient listening. And any questions are welcome.
Thank you. Thank you, Bhavna. Any question from audience?
Madam, by the time you can make few comments,
Okay.
on your
Okay,
side,
okay.
and then we go ahead.
Actually,
Bhavna, you can stop sharing till then.
Yes, sir.
Yeah.
Dr. Bhavna has said very rightly about the hyperemesis gravidarum. Actually, it is the severe type of vomiting of pregnancy, which has got deleterious effect on health of the patient and or incapacitation her day-to-day activity. Actually, it is previously we know about that this is due to the hormonal or something H. pylori or immune, but nowadays it is said that it is due to the GTF15 and it is secreted by the placenta. It rises rapidly and that's why there is a, but it is not present in all the patient. Usually the sensitive one, psychological one, or some genetic. So there is a incidence of hyperemesis gravidarum. Incidence, as you rightly said, 0.3 to 3.6%, and diagnosis is by exclusion of nausea and vomiting during pregnancy. Scoring is helpful in diagnosing the mild, moderate, and severe, and uh, uh, if we proper treatment is not given, then there may be serious side effects that may lead to renal failure, vernish, encephalopathy. Actually, early treatment is required, and treatment is either community level or the ambulatory care or the inpatient. So
I think Dr. Sandhya is here. Can we have one or two comments from your side, and then we go ahead. Thank you for joining.
okay.
Good evening, everybody. Really, Dr. Bhavana, you have told excellently about everything. Not a one point you have not touched like that. Really, it is a troublesome for the clinician to treat the patient is very difficult sometimes. And the patients are also very troublesome to the clinician, ringing every time, what is happening, what are the diet like that. Really, the excellent talk. Thank you, Sneha madam, for giving me this opportunity also and to your team. Thank you, madam. Thank you.
Thank
Thank
you.
you, respected chairpersons, and thank you, Sneha ma'am and Parag sir again.
Thank you, Sneha,
Thank you.
Dr.
Thank
Sneha, for
Thank you,
giving
Bhavna. That was
opportunity.
excellent.
Yeah. So,
Yeah,
Dr.
thank-
Bhavna, thank you, the speaker and the chairpersons, Dr. Usha Kumari madam and Sandhya Rani madam, for your inputs. So, over to the second session and over to Dr. Kamble.
Thank you, Supriya ma'am. We'll move forward to the second session, which is early pregnancy bleeding. We have got the eminent speaker, Dr. Priya Gupta, ma'am, and the eminent chairpersons for this session, Dr. B. Kalpana. I would like to introduce ma'am. Yeah. She is the chairperson of Infertility Committee, FOXY. She is the co-director of Postdoctoral Fellowship of Endogyne, affiliated to MGR University, and she is co-chairperson Infertility Committee, TNFOG, and vice president of MOGS, president Madurai chapter of TAPISA, and so many posts she has held, and she has many academic profile is very strong, and so many awards in her credit. And second chairperson we have got is Dr. Ojaswini Patel ma'am. She is the vice president elect National ISOPAB. She is the professor cum project officer PPC Department of OBGY Wimsar Burla. She has so many awards in her credit and so many publications. Her special interest is in high risk pregnancy and infertility. I welcome both the chairpersons and hand over to you now to continue the session. Thank you.
Thank you, Dr. Madan, for the kind introduction. It is my privilege to be a part of this wonderful webinar, Benchmark Episode 3, which is mainly on early pregnancy complications, and the program director being Sneha Boya ma'am, who is a dynamic person known everywhere, and also convener, Dr. Parag Biniwale, sir. Thank you, coordinators, Dr. Supriya and Dr. Madan, for the kind words. And actually, we had blessings of our FOGSI President Jaideep Tang, sir, and also guest of honors, Dr. Arup Kumar and Sridevi ma'am. So the topic for discussion is yearly pregnancy bleeding, which is a very common topic which we encounter in day-to-day practice. And honestly speaking, it is over-treated and it needs a proper investigation to know the cause. And we have Priya Gupta ma'am, who is going to talk about this wonderful topic. She is a senior consultant obstetrician, laparoscopic surgeon, and fertility consultant also in Kota Hospital. She is a president of Kota Obs-Gyn Society, West Zone Coordinator, Family Welfare Committee. Previously, Vice President of Kota, Secretary, occupied the post of Secretary also. She had organized various conferences, Raj Gainikan in 2017, and Managing Committee member of IAGE and AGESR, member of ISAR, member of Society of Fetal Medicine, and she's into almost all the specialities. West Zone Coordinator of Family Welfare. Welcome, Dr. Priya, for your wonderful talk.
Thank you so much, Kalpana ma'am, for your kind words of introduction. First of all, greetings from Kota Society. My sincere regards to each and every one of you present here. And it's a sincere, profound privilege to be here amongst the galaxy of great academicians and all the respected teachers from all across the country. I would also like to express my sincere thanks to Dr. Sneha Madam, the Program Director of the Benchmark Series for Early Symposium on Pregnancy today, the convener, Dr. Parag Biniwale, sir, the coordinators, Supriya Madam and Dr. Madan, sir. And my sincere gratitude to all the respected chairpersons present here. And good evening. And let us start with this topic of in early pregnancy bleeding. I hope the screen is visible, madam.
Yes, ma'am.
Yes, yes.
Thank you so much. So to start with the topic, like as Kalpana madam has said, that early pregnancy bleeding, the word is quite small and simple, but the management and the issues are quite vast, and they really need to have a very practical insight into the topic to understand the management and the basics of the same. So coming to the incidence of this early pregnancy bleeding, sometimes it is referred as first trimester bleeding, and it is a vaginal bleeding before 14 weeks of gestation. Few of the literature, they also extend this early pregnancy bleeding up till 20 weeks of gestation. The vaginal spotting or bleeding occurs in approximately 25% of pregnancies in the first trimester and is much less common in the second trimester. Approximately 1/4 of the pregnant women will experience bleeding in their first trimester. The vaginal bleeding is common in the first half of the pregnancy and usually results from the disruption of the blood vessels in the deciduum or from discrete cervical or vaginal lesion. The provisional clinical diagnosis can be based upon the gestational age and also on the character of the bleeding, whether the bleeding is only a spotting, is it high in magnitude, including heavy flow, what is the color of the bleeding, is it really intermittent or constant, is it associated with pain or not. So all these factors holds a very important place while we take into consideration of any of the patient coming to us with early pregnancy bleeding. The bleeding or pain is common in early pregnancy, but it does not always mean that there is a problem. And sometimes it could be a warning sign of miscarriage. Coming to the introduction part, the major causes of the early pregnancy bleeding, they account maybe because of the miscarriages, that is 10 to 20%, and ectopic pregnancy accounts for 1 to 2% of the early pregnancy bleeding. Bleeding in the very early weeks of the pregnancy may be related to the endometrial implantation. Rarer causes include cervical and vaginal lesions. Gestational trophoblastic disease should always be considered, particularly in the setting of abnormally raised HCG or suggestive abnormal ultrasound findings. Establishing the site of pregnancy is really vital, as failure to correctly diagnose an ectopic can have potentially life-threatening consequences. In general, bleeding is considered to be the risk factor for the poor fetal outcome in the form of maybe the patient may land up with spontaneous abortion, the patient may experience preterm delivery with low birth weight babies in the future. Later complications in the later part of pregnancy may be the placental abruptio, smaller estimated fetal weight, stillbirth, and perinatal death. Because of its timing, sometimes the early pregnancy bleeding might be mistaken for the menses, and such bleeding has been conjectured to account for errors in the gestational age estimation using the LMP method. So what is the pathophysiology behind this early pregnancy bleeding? Early pregnancy bleeding is usually from a maternal source rather than a fetal one. The maternal source may be a disruption in the vessels of decidua, or probably may be a lesion in cervix or vagina and may be not related to the pregnancy itself. In the earlier stage of pregnancies, the cervix can be vulnerable to bleed because we know there is a hypervasculature being grown in pregnancy time. Another common source of bleeding can be due to the abnormal development of the embryo, that is, the fetal abnormality, the aneuploidies. They could be the result, they could be the cause behind the loss of pregnancy and subsequent early pregnancy bleeding sometimes. So the differential diagnosis of the causes, it basically depends whether the patient is experiencing this early pregnancy bleeding in the first trimester or in the early second trimester. So coming to the obstetric causes of the first trimester bleeding, they may include, number one, the early pregnancy loss. It is a term which is interchangeably being used with spontaneous abortion and miscarriage, and refers to basically in the first pre-pregnancy loss. So it is the most common cause of early pregnancy bleeding and may be associated with heavy bleeding. But in the case of early pregnancy losses, the patients typically remain hemodynamically stable. The other causes could be a threatened early pregnancy loss. It is often considered a type of early pregnancy loss in the presence of a viable intrauterine pregnancy, but with a closed cervix. The presence of fetal heart rate largely determines whether the pregnancy will progress to a viable pregnancy, and the threatened miscarriage or the early pregnancy losses are more common in multiple gestations. The other obstetrical causes for the first trimester bleeding may include ectopic pregnancy. It is less common, but can have more serious devastating effect on the patient presenting with early pregnancy bleeding. The other causes could be the implantation bleeding, which involves a small amount of bleed that may occur 10 to 14 days after the implantation of the fertilized egg. Then comes the subchorionic hematoma, which is the pooling of blood between the chorion, that is the membrane surrounding the embryo and the uterine wall, and it occurs around 3.1% of the pregnancies and is one of the most common causes of the early pregnancy bleeding. Then we can have some extremely rare and unusual causes like molar pregnancy or the gestational trophoblastic neoplasia to be the cause of the early pregnancy bleeding, where the patient may present with symptoms like bright red to dark brown bleeding with lower stomach pain and pressure along with nausea and vomiting. The patient may present in the early second trimester with the placenta previa. The patient may have abruption. There are very rare causes of uterine rupture, especially in the case of anomalous uterus, like with pregnancy in a rudimentary horn. Then non-tubal ectopic pregnancies, especially when it is an ovary cervix, they may present in late first trimester or the early second trimester. The other causes, potential causes of early pregnancy bleeding may include the postcoital bleeding. The iatrogenic causes may be because of the medical treatment or intervention, like patient may be taking the steroids, anticoagulants, or may be using intrauterine contraceptive devices. The vaginal and cervical bleeding may be the reasons, as the patient may be a case of fibroids, the polyps, warts, tumors, vaginitis, or a simple trauma in the vagina may present with early pregnancy bleeding. Importantly, these causes may be coexistent with the other causes of early pregnancy bleeding sometimes. The patient with simple infections, the genital infections, they can come up and put up as the case of early pregnancy bleeding. And such kind of patients, they typically have spotting to light bleeding, which is pink or red in color, associated with symptoms like itching, lower stomach pain, burning while urinating, white discharge, bumps or sores on the outer part of vagina. Lower genital tract bleeding, which may be the result from the UTI, strenuous exercise, or bladder cancer. And we should always consider domestic violence and physical trauma as other potential causes of early pregnancy bleeding when all other causes have been ruled out. So coming to what is implantation bleeding. It is defined as a small amount of light spotting or bleeding that typically occurs about 10 to 14 days after conception. It is quite common and is not a sign of problem. And the symptoms of the implantation bleeding, they are similar to the PMS, like mild cramping, lower back pain, headache, nausea, and tender breast. The implantation bleeding is also quite different from the menstrual period bleeding because it is pinkish or slight dark brown in color, whereas the menses are bright red in color. Implantation bleeding are usually spotting. They're not associated with cramps. They don't present with heavy clots. The length of flow is quite 1 to 3 days and consistencies on and off. And in similar way, we can have a differentiation of implantation bleeding from the miscarriage because there's a presence of darker or heavier bleeding associated with visible clots and associated with cramps, especially in a case of miscarriage. Coming to the subchorionic hemorrhage or hematoma, it is a bleeding that happens when the placenta slightly detaches from the wall of the womb. There's a sac which forms in the gap between the two. The hemorrhage size may vary. The smaller ones are most common, but the larger ones may have heavier bleeding. Many a times, the smaller ones, they have only concealed hemorrhage, and the symptoms may include from light to heavy bleeding, pink to red brown, lower stomach pain, and cramping. And this is the USG image of the subchorionic hemorrhage, which appears as a sonolucent area adjacent to gestational sac, which contains an embryo and yolk sac. Now, what about other causes? Threatened abortion. The diagnosis of threatened abortion should be made in patients presenting with early pregnancy bleeding and an ultrasound confirmed viable intrauterine pregnancy. The rate of early pregnancy loss is approximately 11% after the live fetus have been detected on USG. And the risk of early pregnancy loss is increased when there is a subsequent subchorionic hemorrhage. When an intrauterine pregnancy is detected on USG, but viability is uncertain, we should always offer a repeat ultrasound in the next 7 or 10 days to confirm the viability. And sometimes a normal increase in beta HCG level or a normal progesterone level can be reassuring. Threatened miscarriages should be managed expectantly. The other potential causes include the ectopic and ruptured ectopic pregnancy accounts for almost 6% of the maternal death, with risk factors being the pelvic inflammatory disease, previous tubal surgery, previous ectopic pregnancy or IVF conception. These are the potential risk factors for the ectopic pregnancy. The criteria for the management of early pregnancy bleeding depends on the ectopic pregnancy gestations. Once it is diagnosed, whether the patient has to be dealt with the expectant management, like it is done when the beta HCG levels are less than 1000 milli-international unit, and neck cell mass is less than 3 centimeter, minimal pain or bleeding, no embryonic activity, no tubal rupture, when patient has reliable for follow-up and has no barriers for assessing healthcare. Similarly, medical management methotrexate is sometimes considered when the ectopic mass is less than 3.5 centimeter, but surgical management is mandatory when the patient presents with hemodynamic instability. So, how to approach a patient of early pregnancy bleeding? How we should manage these patients when they enter our OPD or the emergency? So the diagnostic approach in early pregnancy bleeding must always consider these parameters. Number one, the hemodynamic status of the patient, the degree of pain and the bleeding. If the patient is unstable, the patient may be a case of ectopic pregnancy or incomplete miscarriage. If the patient is hemodynamically stable, then we can go for further detailed assessment in the form of thorough history taking and examination, and hence proceed for further line of investigations. So the history taking is a very important part, like from our educational days of we are always taught about the importance of history taking. So here is the similar case. It is important to assess the likely gestational age of the patient, number one, the amount of blood loss, any associated pain symptoms. A review of the menstrual history and prior ultrasonography can help establish the gestational dating and determine whether the pregnancy location is known. Bleeding, which is at least as heavy as the menstrual bleeding, associated with clots, tissue, light-headedness, or the patient is having severe syncopal attacks, or patient is having severe discomfort, we should always concern with the risk of ectopic pregnancy and spontaneous abortion. Patient presented with syncope, the chest pain, shortness of breath may point to anemia resulting from significant blood loss, and shoulder tip pain may be associated with intra-abdominal bleeding, which warrants us to shift the patient to the emergency care, and we may need to proceed for surgical intervention for the same. Whenever the patient experiences discomfort in the middle of abdomen, it is usually associated with spontaneous abortion. And whenever the discomfort or pain is lateralized, it may be an association with an ectopic pregnancy. So history taking holds a real importance when we highlight all these factors. And the risk factors of the ectopic pregnancy should always be taken into account. Cervical smear history is relevant, and certain medical conditions such as poorly controlled diabetes, thyroid disease, they are also associated with early pregnancy bleeding, as they have a strong association with miscarriage. Clinical examination. The physical examination includes assessing the vital signs, number one, and then performing a thorough abdominal and pelvic examination. Following the initial assessment for any evidence of hemodynamic instability and anemia, abdominal examination may reveal the areas of tenderness, guarding, rigidity, and signs of distension. The fundus will be palpable above the pubic symphysis when the uterus reaches the size appropriate for 12 weeks of gestation, and the uterus may be palpable earlier in a case of multiple pregnancy, gestational trophoblastic disease, when the pregnancy is associated with the pelvic or uterine masses such as fibroids or ovarian cysts. A pelvic speculum examination may reveal non-obstetrical causes of bleeding, such as bleeding from the vagina and cervix, and it also helps in assessment of the amount and the origin of the ongoing bleeding. It may also show visible products of conception which are suggestive of an incomplete abortion or miscarriage, and the tissue present in the cervical os should always be removed and to be sent for HPE confirmation. Bimanual examination allows assessment of the uterine size, dilatation of the cervical os, pelvic tenderness, and the cervical motion tenderness. Pelvic and cervical motion tenderness need for immediate further investigations and management accordingly. So after thorough history taking, after a detailed physical examination, including the per-abdominal examination, per speculum, and then a thorough PV assessment, we need to subject the patient to certain line of investigations. So first of all, we should always take into account a review urine sample to be tested for pregnancy. A combination of ultrasound assessment and measurement of serum SCT are required to determine the location and viability of an early pregnancy when the woman has presented with bleeding and the patient is stable. We should always test for the maternal blood group and Rh antibody status. So what is the importance of these investigations? Let us highlight one by one. The importance of beta SCG. The beta subunit of SCG can be detected in the plasma of a pregnant woman as early as 8 days after ovulation, and the quantitative serial estimation can help us provide useful information in early pregnancy. The rate of beta SCG increase is less rapid as the level increases. For symptomatic women with a viable intrauterine pregnancy, the initial beta SCG levels of less than 1500 milli-international unit per ml in 1500 to 3000 and more than 3000 will have an increase over 48 hours by at least 49%, 40 and 33% respectively. The serum SCG levels are expected to rise exponentially up to 6 to 7 weeks of gestation, increasing by at least 66% of the previous level. Before 10 weeks of gestation, slower rate of increase suggests early pregnancy loss or maybe the presence of ectopic pregnancy. By approximately 10 weeks, the beta SCG level typically plateaus or decreases, after which serial ultrasonography is the preferred diagnostic tool. And following repeat measurements separated by 48 to 72 hours, a falling SCG is consistent with the non-viable pregnancy, but does not indicate whether the pregnancy is a failed intrauterine pregnancy or an ectopic, and plateaued a very slow rise of levels of SCG that is less than 50% in 48 hours are suggestive of ectopic or a non-viable intrauterine pregnancy. However, the note should be taken that apparently appropriate rising SCG levels are found in around 21% of the ectopic pregnancy. Now, we were also talking about the investigation. It's a simple, basic investigation, the Rh factor.
And Dr.
But
Priya?
it should be, yeah.
Sorry to interrupt. Can you
Yes,
just go little faster about this investigation little quickly because time is.
Yeah, sure, ma'am, sure. So like we have talked about the blood grouping, that is really important along with the Rh factor assessment. If the patient is found to be Rh negative, then we need to administer the immunoglobulin in a case of early pregnancy bleeding. Then serum progesterone levels measurements, there's also a meta-analysis was done, which has evaluated the accuracy of a single progesterone test to predict the pregnancy outcome in women with first trimester bleeding. It showed that the level less than 6 nanogram per ml reliably exclude the viable pregnancy. Then hemoglobin should be done to assess the level of anemia, and the management has to be done accordingly. We have talked about the role of ultrasonography, the embryological events of the early pregnancy. We all know it occurs in a predictable stepwise fashion. So deviation from this established pattern should raise the suspicion for early pregnancy loss or the ectopic pregnancy, and there are various guidelines which can help us arrive to the proper diagnosis. And transvaginal ultrasound modality has to be considered, especially when it comes to pregnancy bleeding in the first trimester. A non-viable pregnancy, as we all know, when there's a mean sac diameter is more than 25 mm and there's no live fetus in the gestational sac, then it is a indirect evidence of early pregnancy failure. If there's a CRL is almost equal to or more than 7 mm and still we are not able to find the fetal heart activity, then this also points to the case of early pregnancy failure. And if we encounter an adnexal mast, which is the most common ultrasound finding in ectopic pregnancy, that may warrant us to manage the patient on the guidelines of ectopic pregnancy. There's always a discriminatory zone. I would just like to say one thing, that there are particular settings of this beta HCG levels. At particular beta HCG levels, the intrauterine sac should be visible. So this discriminatory zone definitely differs from the observer, from the ultrasound machine, but usually a current discriminatory level of 1500 to 3000 milli international unit per ml is typically used. And at such levels, the intrauterine sac should be visible. So it will help us in differentiating between the intrauterine and the ectopic gestations. It is the same of what I've discussed earlier. And accordingly to the presentations, the USG presentation, the clinical presentation, we can categorize the different causes of first trimester bleeding and the early pregnancy loss. Many a times we have seen we are not able to locate the gestational sac either intrauterine or extrauterine. In such cases, it may be a scenario of a pregnancy of unknown location, and we need to closely monitor the symptoms in stable patient with serial quantitative beta HCG testings and repetitive ultrasounds to localize the sac as possible. And you should always warrant the patient for the emergency signs so that patient can report to our emergency if encounters any of them. The management of the early pregnancy bleeding depends upon the severity and the underlying cause. The early pregnancy loss can be treated with watchful waiting, medication, or uterine aspiration, and the decision should be a shared decision between the mother and the care provider. Those who are having a significant blood loss and they become hemodynamically unstable has to be thoroughly investigated on the lines of ectopic pregnancy and sometimes the incomplete abortion, which may be the reason for the same. Expectant management is only feasible when the patient is expected to have early pregnancy failure. And watchful waiting is usually less effective when it is a case of an embryonic gestation. Patients may switch to medical management, like they can opt for medical abortion, like in the form of mifepristone and misoprostol combination, or the patient can opt for uterine aspiration at any time. Medical management is done by the most effective regimen of oral misoprostol 200 milligram, followed by 48 hours later by 800 microgram of vaginally administered misoprostol if it has been proven case of pregnancy failure or an embryonic gestation or an embryonic demise. Uterine aspiration is the preferred procedure for the surgical management of early pregnancy, and compared with sharp curettage, vacuum aspiration is more comfortable as it is associated with decreased pain. Office-based uterine aspiration is also safe and less expensive option, offering more convenience to the patient. And follow-up with psychological support after early pregnancy loss should always be considered. So this is the management protocol for early pregnancy bleeding in totality, which begins right from physical examination. If the patient is having peritoneal signs or instability hemodynamically, we need to resuscitate and consider immediate intervention. Non-obstetrical causes, we need to diagnose and treat as indicated. If you find products of conception visible on examination, we have to manage the patient on the lines of incomplete miscarriage. And if the patient is stable and there are no products of conception or other causes of bleeding are not identified, it is always wise to perform a transvaginal ultrasonography and obtain serial beta HCG levels to differentiate between the ectopic, viable intrauterine pregnancy, non-viable intrauterine pregnancy of unknown location. and accordingly, the case has to be managed. So thank you so much, and thank you so much for your patient hearing. Thank you, madam.
Thank you, Dr. Priya, for your exhaustive deliberation and detailed discussion on the bleeding in early pregnancy. At the outset, I am thankful to the organizers of this event benchmark webinar. Special thanks to Sneha Buyar madam for giving me the opportunity to share this important session as chairperson. So Madam Priya has told all these events, all these points regarding the early trimester bleeding, starting from the implantation bleeding to the catastrophe of this ectopic pregnancy and also the molar pregnancy. She has not she has told everything, starting with the physiological aspect to the clinical presentation, how to examine, how to manage, and always the 4 points in examination is the proper history taking is definitely having a very good role to differentiate the different causes, and the general physical examination, and abdominal examination and pelvic examination. To add to this, there are so many investigations that are available. Because Madam has highlighted about the blood grouping, that is a must for any woman, whether it is a spontaneous abortion or an induced abortion, other investigation as and when necessary. So thank you, Madam, for describing such a long topic in a span of 20 minutes. Thank you, Madam.
Thank you, madam.
Thank you, Dr. Ojaswini ma'am. Dr. Kalpana ma'am, do you want to add something?
Actually, it was a wonderful lecture. Such a complicated topic made into simple presentation with guidelines you have given, literature evidence. It was amazing, and I've learned a lot. Thank you so much.
Thank you so Thank you so much, respected chairpersons, and thank you, Sneha ma'am, Parag sir, and the coordinators, Dr. Madan sir and Supriya madam, and all the esteemed dignitaries. Thank you once again.
Yeah, thank you. Yeah, amazing presentation. Thank you.
Thank you, Dr. Priya. It was wonderful. Thank you, Priya madam and both the chairpersons for sharing the session. Now I hand over to Dr. Supriya ma'am for next session.
Thank you, Dr. Madan. We come to the third topic. This is the diagnosis and management of hydatidiform mole. And now the speaker is none other than Dr. P.K. Shekharan sir. And to chair the session, we have Dr. Bharti Maheshwari madam. So kindly, madam is professor and head department of OBGY and IVF. She's Muzaffarnagar Medical College. Then she is chairperson Foxy MTP. She was chairperson Foxy MTP Committee 2018-20, fellowship in medical education and governing council member ICOG, secretary UPCOG. She'd been the president of Meerut OBGYN Society, and she had authored so many books, delivered so many orations, and she was also the national coordinator MTP Committee 2015. So madam has many accolades to her credit. Madam, welcome to this forum. And the next chairperson is Dr. K.S. Jairani Kamraj. She's a very, very vibrant personality. She is Associate Secretary, World Association for Sexual Health, Advisory Committee member, World Health Association for Sexual Health. Madam is member Joint Organizing Secretary, ISAR, then 2015, member of board. And then she has got many awards, medals, Best Doctor Award by Dr. MGR Medical University, Chennai, and many more. So madam has has won so many accolades. So madam, just welcome you. And now may I request the chairpersons to kindly introduce the speaker.
Thank you, Supriya. I think Bharati madam is here.
You can go ahead. Jairani, please go ahead.
Yeah.
All right. Okay. Thank you, chairperson. Thank you, Sneha, for this nice benchmark of your creation, which marks a benchmark for many of the obstetric topics. Really amazingly, you are doing your work. Very hats off to you. And with Supriya, who is still more dynamic with all her every day coming in every webinar, making a lot of impact on the knowledge distributions all over the country. And I really thank you both for having this wonderful benchmark series, which is really a good knowledge sharing platform. Thank you so much for making me a part of it. I have the great pleasure and honor to welcome and introduce Dr. P.K. Shekharan sir. He is the former professor and HOD of the Common Medical College, Calicut, Sir is the president of the Kerala Federation of OBGYN in 2003, and he was the vice president Foxy in 2010, and he was the secretary of the International Society for the Study of Gestation Trophoblastic Disease between 2013 and 17, and he was the chair of the World Congress of GTD, and he has co-authored the FIGO guidelines for the gestation trophoblastic diseases 2015, 2018, 2021, and very many publications, more up to the range of 50 and 407 with citations. And sir is the right person and apt person to speak on a very important topic of about the gestational trophoblastic disease. So even now with an ultrasound, diagnosis is very made easy because every pregnancy has been confirmed with an ultrasound, pelvic ultrasound. We detect trophoblastic disease very early, but still the consensus, the guidelines, and the treating, early detection, and the management protocols have made it so wonderfully. I think we have to be very grateful to you, sir, for making a lot of guidelines right from way back 2007 till 21, with all your knowledge and vast experience in dealing with very many cases. And you are the right person to talk on a very important topic of this diagnosis and management of gestation trophoblastic diseases. Though ultrasound made it easy, but still, once it is encountered, we have to know what are the guidelines to manage it so that we give a woman a very important benign condition which may turn into any type of like a malignancy. Once we know the proper protocol of managing it, we'll definitely give her a good quality of life. So with these words, I welcome you, sir, and over to you for your talk on diagnosis and management of gestation trophoblastic disease, sir. Over to you, Shekharan, sir.
Thank you, Dr. Janani Kamraj, for that very nice words. And let me share my slide first.
Yes.
Okay. So thank you, Dr. Sneha Bayar, my dear friend Parag Biniwala, and respected chairpersons, Dr. Bharati Maheshwari and Jarani Kamraj, all other senior faculty and chairpersons, and my dear colleagues. Now, trophoblastic disease is a spectrum of benign and malignant conditions. It is unique in the sense that this malignancy on the mother is from a tissue of her fetus. It is not her tissue which is turning on to malignancy. But that way it is a very unique thing. But we are having a very favorable condition to treat and diagnose and treat and get a cure. So we are not that very unhappy, even though it is an unhappy situation. The importance is that if you do not take care of this benign condition, it may become really malignant and later on cure may not be possible. So the above statements are very important, that gestational trophoblastic neoplasia is one of the most chemosensitive and highly curable cancer, even with the presence of metastasis, often with the preservation of fertility potential. So that is it. Even the high-risk cases, very extensive metastasis, can also expect to get a cure. This is because it has got a very sensitive tumor marker, the HCG, and it is very effective chemotherapeutic agents are available. 50% of the GTN develops following hereditary form. And lower GTN diagnosed early can achieve 100% cure. So GTN following HMOL should be diagnosed early by proper follow-up after molar evacuation. That is our concern. Today's presentation is on that, how to follow and how to make a diagnosis following a molar biopsy. Now, the peculiar thing about the molar pregnancy is that it results from abnormal gametogenesis and fertilization. It is actually an abnormal ovum that is leading to the development of this condition. It is common in extremes of reproductive age, that is in very teenage girls and very elderly women, where the abnormal ovum are more likely to be produced, or the frequency is more in that extremes of reproductive age. The incidence is varying from 1 to 3 per 1,000 deliveries And once a molar pregnancy has occurred in one woman, and she is at risk of 1 in 100, that the next pregnancy may be 10 times more risk than the general population. Now, GTD is the combination of all the benign and malignant conditions. The benign conditions are complete hydatrophic mode and the partial hydatrophic mode. And the malignant ones are invasive mode, choriocarcinoma, placental site trophoblastic tumor, and epithelial trophoblastic tumor. So that malignant ones are grouped together as gestational trophoblastic neoplasia. And to make a treatment or diagnosis, you don't have to have tissue diagnosis, because tissue diagnosis may not be possible unless you do a hysterectomy, and you can start treatment on the level of, or make a diagnosis on the level of the sensitive, very sensitive HCG level. So that is how the classification goes. Now, the hydatrophic mode can be partial or complete with a different, these are different symptoms. In both the conditions, there is an overexpression of the paternal gene, and this leads to trophoblastic hyperplasia and anaplasia. And this may be the reason for the maternal combination contribution in complete hydatrophic mode is not there. It is all from the paternal side. And in partial mode, there is double dose from the paternal side with the one from the maternal side. So there is always an overexpression of paternal gene in the trophoblastic disease, which is leading to the trophoblastic hyperplasia. There is no embryo seen in complete mode, but in a partial mode, there can be an early embryo which may die at the early period or may continue to grow to a later stage. Now, to differentiate between the two, other than the clinical, morphological, and histopathological finding, there is a molecular level of diagnosis, which is by identifying the gene P57 KIP2 on the histoimmunochemistry or by the fluidity study. Now, the formation of the complete mold is resulting from fertilization of an empty egg without the maternal component there, and that is being fertilized by a sperm containing 23 eggs, which is duplicate to form the 46 egg cells, and it multiplies rapidly to form that trophoblastic tissue without an embryo. Embryo, if at all there, it disappears within a 1 millimeter size. So that is the complete mode with the nuclei is having only the paternal compound. While in the partial mode, there is an embryo which is formed by fertilization of an ovum containing the 23 haploid X chromosome, which is usually fertilized by 2 sperms. Usually in the normal fertilization, the ovum should not allow more than 1 sperm to enter. And that's why we said it's an abnormal fertilization. This is abnormal, again abnormal. So this will form cystine XXY or XXX or XYY. So different combinations of it. So that is a partial mode, which will have a slow hyperplasia, lesser possibility of persistent disease and choriocarcinoma, which is very rare. But in complete mode, the potential for going for a malignancy or invasive mode is almost 15 to 20%. Almost 3% of those cases can turn into choriocarcinoma also. The potential for the partial mode to turn into malignancy is just 1 or 0.5 to maybe maximum 3 or 4%. Now, there is another variety of the mode, which is due to a mutation of the gene NLRP7 or KSDC3L, which results in recurrent moles in family. That is, sisters may develop unsuccessful pregnancies, and some of them are diagnosed with the complete mole. And this is known as the familial recurrent complete hydatrophic mode, which is as a result of the mutation of the gene NLRP7 in almost 70% of the condition, and about 10-15 cases it may be SDC3L, or there are some other genes are also identified. So that is the biparental complete hydatrophic mode. This is the genetics. Actually, there is a genome or the maternal genome is there, which is imprinted or silenced, and it's only the paternal genome which will be influencing the development into a complete mode. The maternal genome is imprinted or silenced due to certain methylation problem, and this also will have recurrence because it is a mutation of the gene in that particular patient or in the family, and they can never, or it's a very, very rare chance to have a normal baby. So they are to be given ovum donation, IVF, or some other thing to have the baby. Now there is yet another variety of the mode, which is a twin pregnancy. One is a complete mode, and the another one is having a normal pregnancy. And this can be very dangerous with a recurrent bleeding or hyperemesis or preeclampsia requiring probably intervention, surgical intervention, blood transfusion. But this particular case, we can carry it on to 38 weeks and we could have a normal baby. And you can see the lower part is the degenerated mode. This is just one case what we came across, and that is another variety. So you have got all the varieties of vascular modes. And if you just take if you take a section from this area of the placenta and see it under the microscope, you have got the villi lined inside by the cytotrophoblast and outside by the syncytial trophoblast. You have got the implantation site, intermediate trophoblast, and there is a chorionic plate which will contain the chorionic type of intermediate trophoblast. So this is the cell structure of a complete or partial mold, syncytium and cytotrophoblast. Both will have hyperplasia, and that will produce lots and lots of HCG also. Now, the intermediate implantation of the intermediate trophoblast will give rise to occasionally the placental site trophoblastic tumor, which will not have that much of HCG. And this type of tumors are not very sensitive to chemotherapy, and it requires surgical treatment. The epithelial tumor is a variety of implantation site intermediate trophoblast tumor. It is arising from the chorion of the cyst. So that is the histological basis of the tumor site. Now, presentation is always with the regular vaginal bleeding. Almost 99% of the cases of vascular mold will present as a bleeding, which used to be the story, but it is all different now. There can be excessive nausea, vomiting. The patient who is a multiple gravida who never had any hyperemesis in the previous pregnancy, this time she may have it. You have to suspect either twins or vascular mold. And the excessive size of the uterus, presence of thick agglutinin, development of preeclampsia before 20 weeks of pregnancy, effect of something like hypothyroidism because of the excess HCG level, there can be RDS. So all these are seen in pregnancies which were going beyond 14, 16, 20 weeks. And we had cases which have got to 24 weeks and the size of the abdomen may be 28, 30 weeks, and we have dealt with those cases. Luckily, these are not seen nowadays. And now this type of classical presentation may not be seen in case of present day molar pregnancy because the use of the ultrasound very early. The patient will first do without even missing a period. They will do the pregnancy test. If it is positive, they will go and do a ultrasound study, and they will come with the measurement of the HCG and ultrasound finding is given to you to say what it is. So it is all different way of presentation nowadays. You diagnose with ultrasound and the classical finding. HCG measurement will be very high values you can get in trophoblastic disease. Histopathology will tell us whether it is complete mold or partial mold, or you can go for the higher level by the flow cytometry, whether it is deployed as it is in partial mode or deployed in a complete mode. P57 KIP2 immunostaining can give a diagnosis which is negative in CHM because this gene is present in the maternal allele and that is absent in complete mode, but it will present in partial mode as well as in normal pregnancy or in abortion. So you can't distinguish there, but you can distinguish between partial mode and complete mode. So this is the immunostaining. This is complete mode without any this. This is the immunostaining that we can see the dark brown nuclei stained by this the staining on the P57. You don't go to that level, but it's all on the differentiation may be required in some other cases, so that is all available. What we were doing is with the availability of scan, if it is beyond 10 weeks, this is the classical picture of a complete mole, snowstorm appearance. That the moment you keep the probe onto the abdomen, you can see that it is very sure that it's a molar pregnancy. With the presence of theca lutein cyst on bilateral, which is again pregnancy has to go beyond 12 weeks to have these classical findings. Or it can be a partial mole with the focal molar changes with an embryo or fetus. Again, the diagnosis is easy. So, in cases where you get that classical findings, your diagnosis is sure, but some of the partial mole may be diagnosed as missed abortion and may be evacuated. Now, the problem nowadays, patients will, within 6 to 7 weeks, they will have the pregnancy test positive, they will have an ultrasound finding, and they may diagnose it as irregular sac, and maybe diagnose an embryonic pregnancy or irregular gestation. That madam was presenting about the early trimester bleeding, and these are all getting medical abortion. Maybe she is aborting at home, and there may not be an histopathology done. As it was not diagnosed as a molar pregnancy, she will not naturally have any follow-up also. And she will have an, do not prevent an early evacuation or early expulsion of the molar tissue does not prevent the GTN. That is the other thing. Even if it is early aborted early or removed early, the incidence of GTN is the same in the group. It can be 15 to 20%. So you are missing that chance. That is what is happening now. We have got the cases coming at a late stage also. This particular case come to us at 7 weeks or so. She was asked to have a HCG measured because they were not willing for any terminal. They want to have confirmation that it is abnormal. Anyway, they left the place and came after 2 weeks, and the HCG has gone up like anything. If you are having doubt, you check the HCG. If it is rising, it is either doubling, it is normal pregnancy, or very high, you can suspect that it is abnormal pregnancy like molar pregnancy. If it is coming down, it's a missed abortion. So classically, by the 10th week, you can see. So ultrasound will not show the findings of a molar pregnancy below 9 weeks. And many of these cases are getting aborted below 9 weeks or 6, 7 weeks. As a case of an embryonic pregnancy or missed abortion, we cannot afford to have this everybody having histopathological study, nor the tissues available. So we have to have something else to prevent. Because these patients, even though they had an abortion early, it will not prevent the occurrence of a GTN later on. Now, just to do in such cases, any case of abortion, please make it a point to check the urine HCG at least in those patients at least after 1 month. Anybody who has had an abortion. It is difficult to have the histopathology done for every patient. It is expensive and laborious also. But at least do a simple pregnancy test after 1 month. Any term pregnancy HCG will become negative by 10 to 14 days. Any induced abortion, it will be negative by 4 weeks. It's only the gestational trophoblastic disease which will go on like that. So if it is positive over 4 weeks, please have a check on her HCG. It could have been a molar pregnancy which was unnoticed and without any suspicion it got aborted. But we had cases coming with lung showing secondaries, brain showing secondaries, following just an abortion. So just a simple thing, please do a beta HCG after at least a pregnancy test after 4 weeks in all abortions. Now, the management of the molar pregnancy, it is evacuation. You should do the complete blood count, including the platelet count, HCG, pre-evacuation, chest X-ray, LFT, RFT, and thyroid function test before doing an evacuation, and a blood group, and arrange for the blood because she can bleed. Even if it is 10 weeks or 12 weeks, the bleeding can be profuse. Now, the primary management of an molar pregnancy is suction evacuation under anesthesia, irrespective of the size of the uterus. That is, whether small or big, it is suction evacuation. You can do the preparation of the cervical ripening can be done with a PGE1 kept 2 to 3 hours prior to your planned evacuation. It is not to make an abortion because it is feared that if you make a strong interaction with these prostaglandins, there can be problem of dissemination of the cells. Oxytocin can be given to control the to promote the uterine contraction, urine evacuation. Some of the guidelines say that only at the end of the evacuation you start the oxytocin. But if you are afraid of the bleeding, or if there is a bleeding, or if the uterus is more than 10, 14, 16 weeks, you should start the oxytocin with the beginning of the evacuation itself to prevent the bleeding and also to prevent the perforation of the uterus because uterus will be contracted. You may not miss it. And you have to dilate the cervix about 12 millimeter cannula has to be introduced for suction. If it is 14, it is very good. At the end, you have to do a gentle curettage, and if it is she is RS negative, give anti-D. Now that is the evacuation. You have to keep the suction cannula just above the internal os. Don't push it across and start having the suction on. All the moles will come out gently, and then finally you can have a gentle curettage also. You can, if the uterus is big, keep a hand on the abdomen, the uterus, and then have a control of it. And you can see suddenly the uterus is getting reduced in size and the bleeding. As you just put in the cannula, there can be very heavy bleeding. Don't get afraid and don't stop it. Continue to evacuate and then do a gentle curate. And we were giving oxytocin at the time of evacuation because at that time uterus was minimum 14, 16 weeks in all the cases. Nowadays only it has come to 10 weeks or 12 weeks. And it's a good sign that people are coming early for a consultation. But you may miss the diagnosis. It may not be even found on ultrasound, and you will miss the histopathology also. Now, this is the vesicular molds getting collected on the suction bottle, and you take it for histopathology also, even if you see that it is very clear. Now, occasionally there may be a case which may be taken for hysterectomy with the mole in situ, but you know that hysterectomy is a very major procedure compared to an evacuation. We have done it earlier with a very grand multiparous on 8th gravida, 9th gravida, 45 plus years. We have done 10, 15 cases hysterectomy with the mole in situ. The only thing is it will not produce any invasive mole after hysterectomy, but she can have metastatic disease in spite of a hysterectomy. So they should be also in the follow-up protocol. This is one of the patient who was 42, 43, I think, grand multiparous one, and we had done hysterectomy, but that's not necessary. We can have the evacuation and follow. The question of chemoprophylaxis, whether you can give one course of chemotherapy at the time of evacuation or hysterectomy to reduce the incidence of GTN following the evacuation. Now, this is not useful if it is not a high risk. Only in high risk mode, which is the patient is 40 years and above, HCG level at the time of evacuation more than 100,000 units, and size of the uterus is more than 4 weeks for the period of amenorrhea. So these are the high risk factors with the theca lutein cyst bilateral more than 6. So if these patients are given chemotherapy, the incidence of GTN from 15 or 20% will come down to 8% or even to 3%. But if that patient develops GTN afterwards, she becomes resistant to that drug what you have given, and they may have much more courses. So we haven't given any prophylactic chemotherapy, but it can be thought of in a situation where the patient is not going to have any reliable follow-up and the patient is of high risk mold. I think there is a place for giving a course of or one injection at least of methotrexate or actinomycin D at the time of evacuation, which has found to be reducing the incidence. That is something, but that is not the idea. Now, follow-up after evacuation has to be carefully planned. You will have a pre-evacuation HCG level, if not done at least after one day or the next day. After evacuation, we usually keep the patient one day in the hospital because she can have a bleeding, and also to give antibiotic because there is no membrane in that pregnancy and there is always chance of infection. So give antibiotics and keep her in the hospital. If at all any blood required, still you have to correct the anemia, and then patient has to be called for a HCG as well as for ultrasound after 1 week. This is very important because most often nowadays the persistent irregular bleeding and the increase in level of HCG is due to the incomplete evacuation of the mole. And unnecessarily patients are being sent for MRI, repeated thing, and even starting on chemotherapy also. It is just because the complete evacuation was not possible at the initial staging, nothing wrong. It can happen. So call the patient for a ultrasound after 1 week. If there is something remaining inside, then you have to do a repeat curettage, again gentle, and then any rise in the HCG is not due to incomplete evacuation, it is due to GTN. So make sure that you have made a complete evacuation, and that's why nowadays it is recommended to have the evacuation done under ultrasound guidance so that you can see and say that it is complete. Otherwise, you have to call them for a USG and do a complete evacuation. HCG and clinical follow-up, you have to examine the patient, ask for any symptoms, any vaginal bleeding, or general examination, any persistence of the lutein cyst or appearance of it after evacuation, or enlarging in size, or any vaginal bleeding, subinvolution of the uterus. Sometimes, occasionally, so early also, you can see the vaginal nodule coming. So, have a clinical examination, ask for any symptoms, cough or bleeding, and then do the HCG every week. The HCG assay should pick up all the, in cancer, it is most of the abnormal HCGs will be. The normal HCG is with the alpha and beta chain. We say it is beta HCG because the alpha chain is the same for FSH, TSH, LH, and the like. So the antibody is produced against the beta chain, and that is why we call it as beta HCG. Actually, it is picking up the complete HCG of alpha and beta chain plus the beta HCG, sometimes free circulating beta HCG is also there. There can be abnormal HCGs like core HCG, NIC free HCG, beta core, and so many varieties. The assay system should pick up all these because in cancer, all the abnormal forms are more. And it is found that the Siemens Simulite technique, the assay system, is the one which will. In malignancy, again, there is what is known as the hyperglycosylated forms of HCG, which will come up in cancer. So the HCG assay system should pick up all those things. You have to continue the HCG clinical examination every week, but it is okay that even if you do it once in 2 weeks, because we were collecting the blood for initially, I'm talking of 1990s, where we were not able to get the report every week. So we were collecting it for 2 weeks and then getting, and we never missed any. So you can put it as once in 2 weeks also, not to worry. And you should have -3 more. Once it has become negative is not 0. It can be 5 or 10 as per the lab. So don't worry again. It is up to 5 is taken as normal. And ask the lab what is your norm. And once it has become negative, which can be 5 units or so, then do another 3 more. And once it is remaining negative for subsequent 3 more assay, then it is negative. And then do the test only once in a month, and within 6 months you can stop the follow-up if it is remaining negative. Afterwards, it is very unlikely to have a secondary rise, which is less than 0.1%. So normally we stop it at 6 months follow-up if everything is. In a partial mode, after normalization, after 1 month, if one value is negative after 1 month, she can be let off from the follow-up. She will not develop anything. If the patient had treatment for GTN and subsequent pregnancy afterwards, you have to check the HCG again. That is a subsequent pregnancy. GTN is diagnosed when there is a rise in HCG, which is an increase of more than 10% from the previous value. Over 2 weeks' time, it is GTN. Now again, no tissue diagnosis. Or a plateauing of the HCG for 4 values over 3 weeks. Plateauing means the fall of the HCG is less than 10% from the previous week. Is a plateau, and that is 4 values you should get. Or if the HCG is low but it is persisting beyond 6 months, you have to diagnose GTN. And in case you have got a tissue diagnosis GTN, it is again. So this is how you follow. I think if the time is not there, we will stop here, we will not go. The choice of chemotherapy, whether a single or multi-agent, will depend upon the figure stage and risk score. Probably in some other time, we will talk about if the time is not there. I think I can stop it here, madam. Okay, can I? I can stop it here.
Yes,
because we will not go to the other things. So GTN is treated according to the stage and the risk scoring. So that we will consider in some other time somewhere else. Okay. One more, sir, Madam Sri Devi, Madam has gone. So we are conducting a monthly webinar on GTD, that is 8 p.m. on 8th of every month. I think, Madam, our guest of honor today, Dr. N.S. Sri Devi is the president of this association, National Society for
I'm here, sir. I'm here.
Okay. So, madam will give you the details if you can note down her email. So this time we are having 8th of this month, we are having a speaker from UK. So if anybody is interested, every month on 8th of every month at 8 p.m. we are having this webinar on various aspects of GTD. So let me stop with that portion. I will not go further because you have to have one more speaker there. Any queries? Any queries? Any clarification?
Thank you, sir. Thank you, sir. Bharti madam, yes, you are there.
Yes.
Please.
Very informative and very elaborative lecture on this early pregnancy complication, that is smaller pregnancy. Thank you, Shekhan sir. It is really very informative and all aspects are covered. And as we all know that molar pregnancy is comparatively rare complication, of course. Lekin because of nowadays the awareness and diagnostic availability, we see the patients that they comes with the ultrasound mainly with the molar pregnancy. And as we all know that as sir has told that all patient does not need chemoprophylaxis, only high risk cases. But we should be aware about that what are the high risk cases and how these pregnancies should be monitored and look after in subsequent pregnancies. So patient awareness is also very important. And we have seen many cases of persistent trophoblastic diseases and further consequences. So we should remain aware that after pregnancy, in the many postnatal cases, they delivered somewhere. And sometimes at that time they are not diagnosed. There is some partial more or anything, but they bleeds without any cause. Continuously after many months of the deliveries, and they bleed, and sometimes on the histopathological examination we found that some part of persistent gestational trophoblastic disease. We have seen such type of cases also. So the thing is that we should remain alert, we should remain informed to our all department staffs, juniors and ourselves that such thing can be happen, and follow up is also very important. As we all know that it is easy that we can evacuate, but the thing is that how these patients should be followed till SCG becomes negative even after that. So thank you very much for such a wonderful lecture, wonderful session, and congratulations to Dr. Sneha Puar. I all knows her for a long time. She's such a academic and such a hardworking and innovative person. I must say that she used to do good academic activities, and nice to see everyone in the webinar. And thank you very much for giving me opportunity. And thank you again.
Thank you. Thank you so much, Dr. Bharti and Dr. Jairani, for joining the session and making valuable comments. Thank you so much.
Sneha, best wishes for your election, and you are truly deserving person.
Thank you, my dear. Thank you so much. Thank you.
Thank you. We are over with this session, and I thank the speaker, Dr. Shekharan sir, and the chairperson, Dr. Bharti Maheshwari, and Dr. Jairani. by Janani Madam. So thank you. Over to Dr. Madan.
Thank you, Supriya ma'am. Now, last session, the topic is screening during early pregnancy for common disorders, the updates. And for this session, we have our own Dr. Sneha ma'am as speaker and the dynamic chairpersons, Dr. Anita Sabharwal madam and Dr. Pranjal Sharma madam. It's my pleasure to introduce Anita ma'am. She's the Foxy champion, Wonder Foxy and Foxy superstar, recipient of Foxy Dhira Award, so many awards, and she's president of Forum of OBGY of South Delhi and North Zone coordinator of PSC Foxy. Also, past chairperson of Public Awareness Committee of ISCCP and past chairperson of Adolescent Health Committee AOGD. And so many posts she has held and done the wonderful work in Foxy. I welcome ma'am.
Thank you.
And Dr. Pranjal ma'am. She's the immediate past president of Amravati OBGY Society, and she was dynamic AMOG chairperson also, and director of Sharma Hospital Amravati, and also she was zonal coordinator for AMOGs for 4 years. I welcome Pranjal madam, and over to you, chairpersons, to continue the session. Yeah, thank you.
Thank you, Kamli sir, for the wonderful and very kind introduction. And it's really an honor to be here amongst all of you here. And I have the very pleasant duty to introduce the speaker. And it's the last session, but I think the best session, because our speaker is none other than Dr. Sneha Buyar. And she's one of the gems and jewels in the field of obstetrics. And she's such a talented and hardworking person and a very good human being also. And because I started knowing her when she was the chairperson of breast committee. And I know I also did a lot of workshops with her.
Anita ji, please unmute. Yeah.
So that is what I know about. And everybody just said so many good words for her. So she's a woman of substance. So I don't want to even go through the CV. I just want to say she is the best person we have. And now we will just hear from her lecture, and I wish her the best. I want to see her as our chairperson, Vice President Foxy soon.
Thank you, my dear. Thank you, Dr. Anita ji, for that kind and generous introduction. I will, without much ado, I will just share my screen and straight away go to my topic for today. And because we are talking about this early pregnancy, so right from early pregnancy, what all things you can screen, and of course all of you are agree. All of you will agree to me that the prediction has got a very valuable, substantial role in prevention as well. If you can predict some of the diseases or disorders during early pregnancy itself, and if you have the preventive strategy for that, then definitely you can go ahead with conquering the disease very effectively. And if at all you have to face this, then definitely you are well versed or well prepared for handling this emergency. So all of you know, friends, that pregnancy is basically a natural stage of life. People talk about that it's a natural stage of life, and let it go naturally. If at all you suggest some intervention, then definitely you have to see to it that whatever intervention you are advising or doing for this lady is going to benefit for her benefit her and her baby. So screening in pregnancy is the process of surveying a population of women with markers, defined screening cutoff levels to identify those women who are actually at a higher risk for a particular disorder. So all pregnant women, regardless of their age, should be offered the screening process. Of course, it has to be through an informed counseling process. The option of a prenatal screening test, the most common clinically significant conditions, which should, be for maternal as well as fetal. So prevent maternal and fetal complications. So I'm going to speak only about the screening test and not the diagnostic test. Now you will say what the difference is. Definitely screening tests are only, Sahiti, if you can please mute the rest of the participants, to detect the potential disease indicators, and this is carried on in a large number of asymptomatic but potentially at-risk individuals. The screening tests are usually, they are simple and acceptable. They're highly sensitive not to miss anyone. And of course, they just point towards the suspicion of the disease. They do not diagnose the disease. On the other hand, the diagnostic tests are to establish the presence or absence of the disease. Here, only the symptomatic individuals are subjected to this test, or maybe the asymptomatic ones who are screen positive. And these diagnostic tests may be costly, they may be invasive, but worth the test, because it can establish the diagnosis and can treat the conditions effectively. It is highly specific so that to avoid large number of false positive, and it should promote the definitive diagnosis. So how should be the ideal screening test? The ideal screening test should be, it should detect the disease at a very, very early stage when it is almost asymptomatic. It should have a good clinical outcome. Definitely, there should be some preventive measure. Then only you have some value. Otherwise, if you just say the screen positive and there is no preventive measures, it is of no help. It should be very highly sensitive not to miss even a single, but at the same time, it should be highly specific not to include large number of false positive. It should be relatively safe and cost effective. Now, when we talk about perinatal screening or prenatal screening tests, these tests, as I have already said, that it should be able to identify the mother and the fetus at risk. It should identify the common and important fetal disorders. It should be cost effective and easy to perform, should have high detection rate, and of course, it should be reliable and reproducible. The screen for disorders for which the diagnostic test exists, naturally, when you have a suspicion, as we have already said, that there should be some definitive diagnostic test and preventive measures, then only it is of help. Now, what are these common clinical disorders during pregnancy that we want to screen? We want to screen for anemia. I'm sure, Anita, you are the best person to chair this session. Gestational diabetes mellitus or any kind of hyperglycemia for that matter. Unemployed screening, RH incompatibility, hepatitis B and C, thyroid disorders, preeclampsia or hypertensive disorders, preterm labor, thalassemia, and asymptomatic bacteriuria. Now, why this is so? Because we have a huge burden of anemia. More than 50% of our pregnant women, they are anemic. We have almost 4 to 18%, close to 20% of hyperglycemia. Around 10% women, they do have preeclampsia, and around 13% women, they land up into preterm labor. We do have RH negative women with complication, around 5%. And then, of course, we have the infectious diseases as well. Now, what is the disease burden of this hepatitis? Hepatitis B, the incidence is around 1 to 9%. Hepatitis C is 1%. HIV is 0.7 to 1.2%. Congenital malformations 2 to 3%. Down syndrome around 0.08%. And hemoglobinopathy is 0.04%. Now, why do we need to, and how do we need to screen for anemia? I'm sure all of you will agree to me. The very first point of antenatal contact, that is the first antenatal visit. But in addition to this, at least 4 times during pregnancy, that is 40 to 60 weeks, 20 to 24 weeks, 26 to 30 weeks, and 30 to 34 weeks. And there should be a gap of at least 4 weeks between the two tests. As all of you know that we are talking about Anemia Mukt Bharat, deworming at 14 to 16 weeks of gestation, tablet albendazole. The government is also stressing on the prophylactic iron, but we need to go for the anemia screening. Then only we can provide definitive therapeutic management, though the government is providing the prophylactic iron therapy. So we have diabetes. I'm sure the all of you will always say that India is the capital of diabetes, but definitely we have almost 20 to 25% incidence, and this diabetic population is, increasing day by day, may it be type 1, type 2, or gestational diabetes. And why this is so very important? It is important because almost 60 million women of reproductive age group worldwide, they have some form of hyperglycemia, and this figure is going to double by 2030. So at least 40% of these diabetic pregnancies, they are unplanned. So they have not, optimized their sugar levels. So if you look at this statistics, that the blood sugar levels are directly correlated with the perinatal mortality. So if the sugar levels are more than 200, the perinatal mortality is 35%. And if it is between 150 to 200, the perinatal mortality is 16%. So these are the figures, this bring out this stark necessity for blood sugar control. And that is why all women with diabetes should receive the nutritional counseling and guidance along with the medication to achieve the euglycemia before planning the pregnancy. And they should know what are the optimum or the target levels for sugars. Not going to the details, but we have to just say why pregnancy is diabetogenic. Why? The woman will ask you, I have never had diabetes. Why do you want to test me? Previously, we had this, the age above 35, family history of diabetes, obese women, and those with PCOS. So previously, we had screening only for high risk, but now the concept is changed. And why this is so? The human placental hormones, they are, diabetogenic. They antagonize the action of the insulin. Thereby, they prevent the utilization of peripheral utilization of glucose and lead to hyperglycemia. And this blood with the high blood sugar level enters the fetal circulation. It stimulates the fetal pancreas, releases extra insulin, which utilizes this glucose, extra glucose, and the baby becomes fat. Okay, so now that we have this recommendation of universal screening, not only by DIPSI, but also by FOXI ICOG, FIGO, and the National Health Mission. So all these organizations unanimously say that we have to go for universal screening for GDM or hyperglycemia. That means you have to screen every woman during every pregnancy. And how do you screen that? And when do you screen that? So when do you screen? At the very first antenatal visit, that is first. And if that is negative, then between 24 to 28 weeks of pregnancy. How do you do that? The woman is given 75 gram of glucose, which she dissolves in around 200 ml of water, that she has to consume over 5 minutes, and she has to note down the time. Then after 2 hours, we have to collect her blood sugar, the blood sample for blood sugar level. If that crosses 140, then we label her as having GDM or screen positive. If it is more than 140, it is GDM or screen positive. If it is less than 140, then it is screen negative. But in between 120 to 140, that is what we label it as gestational glucose impairment, GGI. So gestational glucose impairment or intolerance, because these are the women who are high risk, and though not at this point, it may, get rise, or in the subsequent test, she may be positive. So we have to just remember not many values, but this is the only value, 140 mg/% after 2 hours of 75 gram oral glucose. So once you label the patient as GDM, then of course the management part remains. Now coming to the blood group. It is universal screening. All of you obstetricians know it very well. You have been doing it over the time. But RH typing, if the lady is RH negative, we have to ask for the husband's blood group and indirect Coombs test. Of course, beware of the wrong reports from the labs. And sometimes what is called it as RH null. So you have to reconfirm it by the ICT. So that is how the RH negative. All of you are well versed what problems that is not the purview of this topic. So coming to the screening for infectious diseases, we have already talked about the hepatitis B and C, but definitely the group B streptococcus, It is very closely related to preterm labor and perinatal mortality. HIV screening, ACOG recommends routine screening, and all of us are doing this. But definitely we have to follow these guidelines and continue screening. Rubella, hepatitis B, varicella screening. Immunization is offered according to immunoglobulin titer, of course. If at all the lady has received vaccination, we have to ask her for contraception for 3 months at least, if not, at least 1 month, if not 3 months. Screening for Australia antigen, it has to be universal screening. All pregnant women during every pregnancy should be screened for Australia antigen, that is HPS-AG. Why? Because if the woman receive the infection, the post-exposure prophylaxis with hepatitis B vaccine, hepatitis B immune globulin within 12 hours of the birth, the baby should receive. So the baby should receive the active as well as passive immunization. That is what is the rationale for testing. So once you label the patient as having hepatitis B positive, two things. Either we have to know her viral load also, that we have to take care, and then we go for the liver enzyme. So we are prepared for, whatever problem she can land up into. And if at all she doesn't land up into any problem, we have to take care of the baby. We have to vaccinate the baby, active immunization and passive. The hepatitis B immunoglobulin, that is to be given within 12 hours. That is as soon as possible, at least within 12 hours. So coming to the screening for hepatitis C virus, it is a recommendation for universal hepatitis C screening in pregnancy. That is done in US. For us, we are not going for routine screening for, hepatitis C. The government of India it doesn't recommend the routine screening. It is the Infectious Disease Society of America and American Association for the Study of Liver Diseases. These are the organizations which are recommending universal screening for hepatitis C virus. The reason being, if it is done in a pre-conception, then it carries a value because you can treat the patient with antiviral agents. But if this is detected during pregnancy, you cannot give antiviral drugs to this woman, and then the screening is of no use. Coming to thyroid disorders, as a routine, it is not recommended by Government of India, though all of us are doing it, I'm sure, considering our practical expertise and experience. But high-risk women, that is those with deficiency area, those from those who are obese or have had previous thyroid disorders and treated medically or surgically, current goiter, history of mental retardation in the family or previous child, autoimmune diseases, and history of recurrent spontaneous abortion, preterm labor, intrauterine fetal death, the abruptio placentae, and infertility. These are the women for whom we should go for thyroid screening. So universal screening is not recommended by Ministry of Health and Family Welfare of India, but it is preferred for us practitioners. Now, the levels, all of you know this, first trimester, second trimester, and third trimester, we have to just see that the levels are very easy to remember, but we have to make sure that in no trimester or at no point of time, it should go above 3 milli-international units per liter. So these are the national guidelines for screening of hypothyroidism during pregnancy. Now, suppose a patient comes to you with history of amenorrhea, we have to confirm for pregnancy, maybe by urine pregnancy test, or if earlier by beta HCG. We have to go for her basic baseline ultrasound, see that the pregnancy is intrauterine, confirm. And once you confirm the pregnancy it is intrauterine, you can go for fetal pole and cardiac activity. And then you start, right from early pregnancy, start the antenatal care with the basic examination and investigation, the maternal weight, pre-pregnancy maternal weight, and of course the first trimester maternal weight, and then the gestational weight gain. All these points are very, very vital as far as, the complications which can develop later on. So body mass index is very, very important. Urine dipstick and all other routine tests. Maternal blood pressure, both arms. We previously used to take it in lying down position. Now, in sitting position, preferably right upper arm, but in both the arms, there may be some disparity. And then, of course, rather than the blood pressure, mean arterial pressure is very, very valuable. These are the maternal risk factors, which we are using it for just SDP gestational scoring. I mean, in comparison with the very costlier test, this simple measures the history in the points in the history can definitely guide you in scoring the SDP justosis. This if the score is more than 3, the lady is prone for development of hypertensive disorder. So advancing maternal age, increasing weight, Afro-Caribbean and South Asian racial origin, medical history of either chronic hypertension, diabetes, thyroid dysfunction, SLE, antiphospholipid syndrome, and conception by IVF. All of this itself is a very high risk factor. Family or personal history of preeclampsia again will add to the risk. I have already talked about mean arterial pressure. Just to say how it is measured: 2/3 diastolic blood pressure plus 1/3 systolic systolic blood pressure. Normally it should be around 65. It should be examined. The blood pressure should be taken in ideal conditions. We will discuss it at some other talks. Uterine artery pulsatility index. I'm sure all of you are seeing this, early pregnancy near the internal os, and you are taking it the uterine artery pulsatility index, which itself will guide you about the possibility of development of hypertensive disorder in future. So the screening criteria, nice guidelines say that maternal characteristics alone will tell you about 40%, and ACOG says around 5%. This is a prediction. So this is a chart which tells you that how the maternal characteristics alone will help you in prediction of preeclampsia. So 58% for early onset, 50% for late onset, that is after 37 weeks. But the maternal characteristic, when combined with mean arterial pressure, uterine artery pulsatility index, and SLGF and PLGF and SFLT, then the prediction for early onset hypertension is almost 100%, and even the late onset hypertension is 85%. So why not to go for all these screening criteria? So because you have a very effective preventive measure, that is low dose aspirin 75 milligram per day and high dose calcium and vitamin D, because it is described that compliance, if the compliance is 90%, then the prevention is almost to the tune of 75%. All of you know that the etiology of hypertensive disorder is still not understood completely, and that's a very reason the prevention per se is not possible. Now, how do you go for the prediction of preterm labor? Measurement of the cervical length. Routine measurement, the benefits are not known, but fetal fibronectin is also described. Nowadays, there is lots of discussion about this, but the availability, accessibility, and benefits of routine screening is not clear. Periodontal disease, I'm sure we obstetricians are not aware of this, but the pediatrician neonatologists are very much aware of this, that periodontal disease increases the risk of preterm labor independently. The treatment decreases the risk. And bacterial vaginosis and asymptomatic bacteria there, I'm sure you will all agree that these are the independent risk factors for preterm labor. Very classical picture of the short cervix and funneling. But before this, can we have the idea before this? Yes. Transvaginal sonography at 11 to 13 weeks. If that indicates short cervix, then of course you have to do a dynamic cervical length study. That is, if it shortens by more than 2 millimeter per week, then that is to be considered as high risk. But of course, all of you know that unless you rule out the congenital malformations, we don't think of giving us putting a cervical stage. So again, between 19 to 24 weeks, if you do the ultrasound and if you find the cervical length of less than 25 millimeter, then definitely that is a short cervix, and of course you have to consider this as high risk and go for the management discuss. Either you go for cervical encerclage or go for vaginal progesterone. This is just to make you aware, though this is not a part of my study, that women with singleton pregnancies, mid gestation, sonographic short cervix, vaginal progesterone is efficient and safe for reducing preterm birth and neonatal morbidity and mortality. This is what is endorsed by FIGO as well as and it has appeared in American Journal of Obstetrics. So it is the results are comparable with cervical encerclage. That is what it is described. Coming to the screening for thalassemia, I'm sure you will say that all of us are not doing the screening for thalassemia. It's not recommended as universal screening. Only if you have suspicious findings or symptoms, then you can go ahead for the screening for this. And of course, you have certain communities or families where you have the suspicion for thalassemia. So carrier stage for thalassemia, of course, if one partner is carrier, then of course you have to test for the other so that to avoid the baby or the offspring being born as the sufferer. So if whenever in peripherosmia you have in the CBC MCV less than 80, MCH less than 27 picogram, then we have to go for high performance liquid chromatography and quantification of the HbA2 and F. If the woman is carrier, we need to screen the husband. If both partners are carrier, then we have to explain the risk of major thalassemia for the offspring. Screening of other relatives also is advisable here. So screening test for thalassemia, this is just a chart I'm showing you. I have already talked about this, that we have this findings which give you suspicion, and clinically if you have some symptoms like history of jaundice, enlarged spleen, hepatosplenomegaly, growth and developmental problems in any of the members of the family, tiredness, fatigue, anemia. So this is about the prenatal screening for genetic disorders. The suggested guidelines are prenatal testing is the best strategy for reducing the burden of genetic disorders and congenital disabilities that cause significant postnatal functional impairment. So universal parental screening is advisable for common genetic disorders and congenital anomalies. So that is how we are, all of us are following that first trimester screening, NT scan, and preferably the quadruple marker. This is just a study, I think from, this is the stillbirth prevention study, which is, quoted here from UK. We will not go into the details what our FOXY GCPR says about basic essential care recommended for all pregnant women. I would like to quote here that all pregnant women must be considered for regular ANC visits, at least, monthly visits till 30 weeks and fortnightly during the 8th month and every weekly in the 9th month. That is what has been, followed for 80 years and more. I'm sure all of you are aware of the changing or the inverted pyramid of antenatal care. We will talk about it a little later. And the basic investigations of hemoglobin, blood group and RH, VDRL, blood sugar random, and microscopy, immunization with 2 doses of TT and 1 Tdap, or and then of course the iron and calcium, folic acid supplementation, institutional delivery by the doctor or a trained birth attendant, and education on nutrition, diet, hygiene, and of course post-delivery education of the breastfeeding and birth spacing. This is what is the recommendation by FOXY. But to be very precise, what is expected preconception counseling and care, counseling for HIV, antigen, HCV testing, counseling and screening for thalassemia and Down syndrome. Repeat, the blood sugar level should be repeated every trimester. Nowadays, this concept is gone, and we recommend universal screening for what is 75 gram single step OGCT, that is DIPSI test, ultrasound evaluation once in each trimester. That is what is recommended. And this is what the inverted pyramid of antenatal care. The concept has come that it's not that all the complications just come as a guest, they are during the 9th month, but right from early pregnancy, they give you some indication, and that's a very reason at 11 to 13 weeks, you have to triage the pregnancy. If she is, high risk, then you have to put her under specialist care, and then you give her individualized care and individualized investigations. Then, of course, the next visit at 37 weeks. And if she doesn't deliver by 40 weeks, then also again she has to come. Otherwise, she can continue with her family physician or the local obstetrician. This is just a chart which I have talked about. This is my concluding slide. And the cost efficacy of each and every screening you can see here. The preeclampsia, the cost is very, very less. The prevention is almost to the tune of 60 to 70%. 11 to 14 weeks is the time when you can screen and diagnose. Preterm labor, 11 to 13 weeks and 19 to 24 weeks. So definitely well in you can diagnose or predict that this patient is going to land up into preterm labor, and do have effective strategies to, treat the whatever the problem she has. GDM I have talked about, Down syndrome and hemoglobinopathies. So this is the chart, what is already recommended by our organizations, and this is a chart actually which says it's not only the hemoglobin but complete blood count, and of course the HPLC or hemoglobin electrophoresis and peripheral smear. We should do a blood group and RH, should be done as a routine. Urine routine should be done, but in addition, for asymptomatic bacteriuria and the bacterial vaginosis, midstream urine sample culture should be done. The infectious disease, VDRL, HIV, and hepatitis B. In addition, nowadays, hepatitis C and rubella is also added. TSH is advised or recommended, but we should go for the routine, the detailed, maybe free T4 and ultra TSH, and if positive, thyroid antibodies should be done. So ultrasound I have already talked about. It's not only the dating scan and double marker, but the in addition to this, the uterine anti-pulsatility index, the cervical length, and the placental growth factor, PLGF and SFLT. All these should be done. So with this, I conclude my talk, and I hope as a routine, antenatal care, when a patient comes to you for routine treatment, I would say routine antenatal care, what you should advise, what complications you can foresee and prevent. I think I have tried to discuss it to my best, and I hope I have done justice to this topic. So I thank chairpersons, and over to you for your comments, and if at all any questions, I'm here to answer. Thank you so much.
Excellent talk, Sneha madam. I always feel that the way you have worked on shaping yourself academically is simply commendable, madam. Your zeal for working, always I note that it is unmatchable. These are the quality which makes someone a good leader. You are truly a deserving candidate for VP, madam. I am very sure you will win with a large margin, and I request everyone to vote for dear Dr. Sneha, madam.
Thank you. Thank you so much. Thank you, Pranjal.
Really, Dr. Sneha, it was wonderful lecture, so stimulating, so uplifting, very interesting. And I think everybody has seen the true leader in you today. And we need more lectures like this from you, I think, in the coming future also. So that's why we need a vice president like you, so that in a whole community, we can disseminate this kind of, awareness, public awareness lectures, so that we can really decrease the morbidity and mortality in women. So definitely you are going to rock in this coming Foxy election. Thank you so much.
Thank you. Thank you, Dr. Anita. Thank you so much for your all your appreciations and all your best wishes as well. Thank you so much. We do have Madam Sri Devi. I can see Madam still there. If Madam can make few comments. No, I don't think. Yeah, madam is
Yeah,
there.
madam is there. Yeah.
Madam is there. Yes. Hello, madam. I can see the lots of comments. Appreciate madam. Yes, but from
It
your
was a
side.
wonderful event. Every topic very well appreciated. And finally, your topic, your presentation, excellent. All the best for the post of Vice President.
Thank you, madam.
Thank you, madam. Good night.
Thank you, madam. Thank you so much for gracing the occasion as well. And thank you so much for your blessings. Thank you. Thank you so much, Supriya. Over to you.
Yeah, thank you, madam. So now we have come to the end of this wonderful benchmark webinar, madam, with such lovely talk by all of you and especially you. Your talk was crystal clear, crisp, and very informative. So everybody has liked and lots of appreciations to you. So, and I'm very happy to be in the third episode of Benchmark, the brainchild of Dr. Sneha Bhuyar, who is really doing wonders. And madam, really, everybody has appreciated your program. And you must have heard by yourself itself. Then we are so I'll just give a formal vote of thanks that we are very happy to have Dr. Jaideep Tank sir, President Foxy, as guest of honor, Dr. Arup Maji sir and Dr. Sridevi madam as guest of honors, and program director Dr. Sneha Bhuyar, who has taken such pains in spite of her so much busy routine. Everything she manages so well. And madam, really, we all wish all the best for you, and you are really deserving candidate. What I can say, everybody is telling, and lots of good wishes to you for this. And may you always be happy and you get what you are striving for. And madam, one sec. And
Thank you
so,
so much.
yes, madam.
I feel myself always a winner because all of you love me so much. That's
You are. Yes, madam. And I'm so thankful, for all the three speakers, Dr. Bhavna Khera, Dr. Priya, and yourself. And also the chairpersons, they have given their valued time. Dr. Usha Kumari, madam, who's from Patna, Professor and HOD, Nalanda Medical College and Hospital, Patna. She is so prompt. She joined the first punctually and she's still at the end. So, Madam Usha, madam, lots and lots of thanks to you. And Dr. Sandhya Rani.
Thank you, Madam Usha, and thank you, Ojaswini. Still writing the comments for appreciation.
Yeah, Ojaswini, Dr. Ojaswini, Dr. Kalpana, then Dr. Bharti Maheshwari, she also joined, Dr. Jayarani, and then Dr. Anita Sabrewal, who is very favorite of everyone, Dr. Pranjal, and thanks to
Dr. Sandhya Panigrahi, my dear friend, she's here from Odisha, Berhampur.
Yes, then Dr. Parag sir, he is the convener and he's been, and Madan Kamble, he had some emergency, so he called me just now. Otherwise, he's a very nice person and he took a lot of effort in the making of this program, Sneha ma'am. So thank you everyone, and a big thanks to the Sahiti Shield people who have given this wonderful platform to all of us. And thank you all the audience who must be listening to us. So thank you, Sneha ma'am. Thank you, all the best again.
Thank you so much, all of you, once again. And my special thanks to dear friend Parag, who has actually, conveyed this program so well, and my dear friends, coordinator Supriya and Madan. Thank you, all of you.
Thank you. Thank you very much.